or fusion. Perfect. Take home message.
privilege to get valuable information from our valuable doctor, Dr. Naveen. Sir shared us very good slides about DKE. So just keep remembering it and follow the all this information given to you and updating when you're working with your patient. Now coming to the next thing, we are going to have another session in 5 minutes of 2 to 5 minutes of break. We'll all join for the next section. Will be by Dr. Sridhar. Thank you, sir. Thank you very much for your valuable inputs.
അവൈലബിൾ ആണോ നോക്ക് യൂട്യൂബിൽ. Good afternoon to all. Am I audible? Sorry for the inconvenience which happened. Now we'll start with the topic of exercise for diabetes and periarthritis. For that, I would like to invite Dr. K. Sridhar. Sir has done Masters in Physiotherapy, PG Diploma in Clinical Research. Sir is working with us as a consultant physiotherapist and HOD physiotherapy with vast experience. Sir, over to you.
Hi, good afternoon everyone. Hi, good morning everyone. My name is Sridhar, Dr. Sridhar, physiotherapist in Medical Hospital, Madhapur branch. And today on Diabetes Day, we are explaining about the periarthritis of shoulder and some of exercise for the periarthritis. Hello. Hello. ఇది వీడియోస్ ప్లే చేయాలంటే ఎట్లా? Hello, can you hear me? Hi, good morning. Sorry for the inconvenience. I'm Dr. Sridhar, Master's in Physiotherapy and Consultant Physiotherapist in Medicover Hospitals, Madhapur branch. Today, I will explain about the periarthritis of shoulder. Periarthritis is a common condition. It's characterized by the pain and progressive limitation of abduction and external rotation movement of the shoulder. Frozen shoulder is also called adhesive capsulitis. It causes pain, stiffness of the shoulder over time. Shoulder becomes very hard to move. It most commonly affects the people between the age of 40 to 60. Women is more than the man. If you have a chronically high blood sugar levels, sugar molecules may attach to the collagen. This collagen is a major protein that makes up the connective tissue that holds your joints together. When sugar molecules are attached to the collagen, it gets sticky, so that movement becomes restricted and your shoulder will get stiffen. That collagen is affecting, and that redness is the affected joint capsule. Main risk factors for the frozen shoulder is, first one is the diabetes mellitus. Second is the mainly heart diseases, ischemic heart diseases, immobilization due to fractures and dislocation around the shoulder joint, strokes, lung diseases, thyroid also, and strain and the surgical trauma. Mainly the clinical features in this periarthritis are the stiffness of the shoulder, inability to raise the arm. Patient is unable to raise his arm, affected arm, and shoulder mobility will be decreased. Main in the shoulder pain. At all the times, initially at the night times is more pain, and next progress to day also. And radiating pain to the down arm also, and difficulty while doing the activities. Periarthritis is limitation of abduction and external rotation of the glomerular joint. Mainly periarthritis is divided into three stages. First stage is it is called a stage of pain. It just starts with the pain. It's up to 3 to 6 months it will be there, and it's gradually progress to second stage of stiffness. It is stays up to 18 months, and after that it will enters into the recover from the pain, but external movement, rotational movement and abduction is lost. It's a stays up to 2 years also. In first stage, it is a stage of pain. It is the freezing stage characterized by dull aching pain in the shoulder. Pain more severe at night. Pain may be radiates to the down to the arm. Pain will adapt to abduction and internal rotation. In this one, it is treated by in first stage it is worsen more to it will progress to the next stage also. In the next stage is the stage of stiffness. In this one, ADL activities are restricted, shoulder motion is restricted. Patients mainly complaints of the inability to reach is back of the pockets, combing hair, and inability to touch the opposite shoulder. Pain worsen at night only. Night there will be more pain. Then third stage. Patient was not treated in the first and second stage is progressed to the third stage only. And by the time reaches up the third stage, patient is relieved from the pain also. And slow recovery motion is there, but his loss is the external rotation. Aggressive treatment with the physical therapy as close manipulations and mulligan technique. If the conservative management is not failed, then surgical intervention is required. For the this one special tests are patient to perform the touch the opposite shoulder, and passively abduct the shoulder will be painful. Diagnosis mainly by X-rays, MRI of the shoulder, elevated ESRs, and C reactive protein levels are increased. Mean arthroscopy is also be helpful for the diagnosis purpose. Management is mainly of medical management, that is conservative management and surgical management. In medical management, we'll start with the NSAIDs, painkillers and antacids, calcium therapy and vitamin D3. Then in that one conservative management, physiotherapy management is the most important role. The basic aims of the treatment is to reduce the pain only and increase the extensibility of the thickened and contracted capsule of the joint. Improve the mobility of the shoulder. Patient has to lift the shoulder up to full range, that is 180 or minimum of 160 or 170. Then improve the strength of the muscles around the shoulder joint. In physiotherapy treatment, for the treatment progression, we'll divide it into 3 phases mainly. Phase 1 is patient has to perform program under strict supervision of shoulder rehabilitation therapist, which is compulsory of 10 days. Up to 10 days, he has to be come to the therapist and perform the exercise. After that is the second stage starts. Then in the second stage, patient has to perform all the exercise at home for 6 weeks. Then come for the follow up with the doctor. Then third stage, this is the by the time of phase 2 only patient get relief mostly. Phase 3 is mainly required for the sports persons and who has the high demand of activities of the shoulder only. That same as 1 and 2, then we will continue with the 3. In this one, along with the not only with the shoulder capsule exercise, will encourage the core strengthening also for this program. Core exercises are more important for the periarthritis patients. This is an excessive exercise program which includes exercise with a low resistance and high repetitions. With a low weight and low resistance, patient has to perform more times while doing the exercise. In phase 1, mainly of capsular setting exercise, capsular stretches, and core muscle strengthening exercise and rotator cuff muscle strengthening. These are the 4 main exercise pattern we will follow in this one. For scapular setting exercise, I will show the video. Elbows are flexed at 90 degrees and raised at shoulder level. Retract shoulders and placing the elbows down, try to raise forearm and hands off the mat. Slowly release. 1, 2, 3, 5, 6, 7, 8, 9, 10. Okay, only the kudos. From the beginning. Shoulders in the same position. Hold it for 10 counts. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
and gradually extend both arms and hold it while in prone position, elbows are flexed at 90 degrees and raised at shoulder level. Retract shoulders and placing the elbows down, try to raise forearm and hands off the mat. Slow release. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Arms in neutral position. Retract both shoulders.
So,
That's no connection. As both scapula and together. 1, 6 position. Retract axillary stretches. Patient in supine leg. Axillary stretches. Patient in supine leg position. Patient clasp the hands properly. Then the patient has to take it overhead slowly. Up to down. Wait for 10 seconds. Stretches. Patient in supine leg position. Patient clasp the hands properly. Then the patient has to take it overhead slowly. Then above the Buddha. Second one, patient puts the position. After the affected arm of the patient, the elbow flex. Wrist while stretching. By putting on the elbow or asking the patient to apply the patient by compound. Patient in standing position. Ask the patient to face forward even taller. Elbow should be flexed at 90 degrees and forearm must be fixed to the wall. Above position. Forward by putting the opposite leg forward. Has to feel the
my leg.
both shoulders.
Then we will move to the capsular stretches are over. Then next one is the pendular exercise.
Pendular exercise. Patient in forward bending position with the normal hand support and the affected hand should perform flexion extension exercise. 50 times and abduction and pendular exercise. Pendular exercise. Patient in forward bending position with the normal hand support.
Last.
Adduction exercise for 50 times. Clockwise and anti-clockwise rotations.
Then next we will move to the core strengthening exercise.
strengthening exercise. Supine with release flex at 60 degrees. Dumbbell press and very strengthening exercise. Supine with release flex at 60 degrees. Dumbbell press and very contraction. Then pick up the neck slowly. Someone has to feel the contraction between the
Video.
Second one, patient with supine with legs straight, legs elevated at maximum of 30 degrees above the ground to 5, 6, 7. Third technique, side lift. Tummy tuck and both legs elevated at 30 degrees. Patient has to flex one leg of the leg while extending the other alternately. Repeat for 10, slowly release. Exercise say as above 30 degrees slowly, very slowly, go for 10 and release. Attack both shoulders.
These are the four core exercise. We have to continue.
Attack both shoulders. And back your extend both arms. Aim for count of 10. Release gradually. Leave his hands by the side. Retract both shoulders in the same position.
These four exercise, core muscle strengthening exercise. And next one is the muscle strengthening, rotator cuff muscle strengthening. This one, rotator cuff muscle strengthening exercise 3 times a week, 8 to 12 repetitions for 3 sets. For closed chain, isometric strengthening is the next one with the elbow flexed at 90 degrees and the arm side to side. Perform the internal rotation, external rotation, abduction, and forward flexion. Then we progress to open chain strengthening exercise with the TheraBand for the same group of muscles. Progress to lightweight dumbbell exercise for internal rotations and external rotations, abductors and forward flexors. These are the TheraBand exercise with the TheraBand. The other exercise in this one are wall and ladder exercise, the first one, and shoulder and wheel exercise, finger ladder exercises. Up to now we are seen the phase 1 of exercise. Then second phase, it includes the same exercise as phase 1, but patient has to perform at home after learning it properly by trained therapist. It's around 6 to 8 weeks. Third, phase 3 is the protocol standardized for the basic exercise and our masters principal shoulder muscles of like rotator cuff muscles and scapular muscles. Strengthening and optimal stability of the shoulder complex is achieved. It's around 6 to 8 weeks. Thank you.
Thank you, sir. Thank you for the wonderful presentation and the video which you have presented. It will be very useful. Now, let's see the importance of diet therapy in diabetes. For the same, I'd like to invite Ms. Srilata ma'am. Ma'am did MSc Nutrition and Dietetics from Osmania University. Ma'am is a registered dietitian, also has a diploma in home science. Ma'am has received so many awards and recognition, including Dr. APJ Abdul Kalam Sir, Health and Medical Excellence. Ma'am is a life member of so many associations, including IDA, that is International Development Association, NSI, All India Association for Advancing Research in Obesity, and Indian Association for Parenteral and Enteral Nutrition. Ma'am, it's over to you, ma'am, please.
Good morning, everybody. Hope I'm audible. Do let me know if I'm not audible. Okay. So today I'm going to talk about diet therapy in diabetes. So my scope of talk is management of diabetes, glycemic index and glycemic load of foods, diabetes related nutrition knowledge, medical nutrition therapy in diabetes. So how do you manage diabetes? So it's a multifactorial approach usually in a corporate sector where people like us work. There is an endocrinologist, there is a physician, a dietitian, a physiotherapist, and a concerned nurse. So it's a team approach to deal with diabetes. At home, how do they manage themselves? The most important is their drug therapy and diet therapy. So the point to be focused over here is the individual nutritional needs over the customized approach. So we have different types of patient. So we cannot give a blanket fold statement to everybody. In India, every 20 to 50 kilometers, the cuisine changes. So the food habits, the things what they eat, the masalas they add, the mode of preparation differs. So we need to understand their nutritional needs. We have to have a customized approach. Then can we chalk out an excellent plan for them. To achieve and maintain ideal body weight is the most main goal of diabetes. There is an endocrinologist, there is a physician, a dietitian, a physiotherapist, and a concerned nurse. So it's a team approach to deal with diabetes. At home, how do they manage themselves? The most important is their drug therapy and diet. So, for a diabetic patient, the most important goal is to achieve an ideal body weight and also to maintain the ideal body weight. There should be a sustained weight. It cannot be a fluctuating weight. You lose weight today and you're going to gain weight another day. So that is not weight, which is supposed to be an ideal body weight. We need to address the blood sugars, which are really most important, and also to take care of the blood pressures and to reach the lipid target goals. We cannot neglect these three parameters. If we neglect these three parameters, the outcome is very bad. We need to have the complications of diabetes very quickly. So most important thing is to keep the sugars under control, pressures, and to maintain the lipids within the limits. And we have to try to prevent and delay the complications of diabetes. Yes, once the patient is diabetes, definitely in near future he will have complications, but it is manageable, or we can prevent and delay by taking a adequate diet, by going with a drug therapy, and being physically active. Right food choices and options to maintain the pleasure of eating. Most of us say that I don't like this food, this is not my choice. So we need to look at the choice and also see that they are happy in whatever they are eating. Developing healthy eating patterns is most important. We cannot eat at our ease. We should have an healthy eating patterns and do not gorge on outside foods or regular partying and taking large meals. We have to take small frequent meals or 2 or 3 meals a day, with including good nutritious diet with focusing on the nutrients. So most of the people look for the full plate meals or different types of their menu, but we need to focus on the nutrients, not on the calories. Most important point to be focused on. The food should be chewed number of times. We have to consider the chew count and look at the carbohydrate content of it, and also the portion control. We have to cut the carbohydrate. We have to eat good amounts of protein, take large amounts of vegetables, include good amounts of dairy products. This is how, if we control the portion size, we have a hold on the carbohydrate, chew and eat properly, then develop a healthy eating patterns, then absolutely we can manage diabetes within no time. Now, we all know the diagnostic criteria of diabetes and pre-diabetes. So if the HbA1c is more than 6.5, it is diabetes. GGT is more than 200, or RPG is more than 200. Now, the glycemic targets are most important. According to American Diabetic Association, the HbA1c should be less than 7. It is again individualized depending upon their incidence of cardiovascular diseases or high lipid profiles or obesity. That keeps changing. But for an average diabetic without any other ailments, it is less than 7. The postprandial glucose should be around 70 to 130, and it should be less than 180. And the blood pressures should be targeted less than 130 by 80. And the lipids should be again LDL less than 100, but it is always ideal for a diabetic patient to have For patients having cardiovascular diseases, to be a very good cholesterol should be more than 40 for men and more than 50 for females. And your triglycerides should be less than 150. This particular blood lipid will depict about the consumption of carbohydrate. If you are a voracious carbohydrate eater, your triglycerides goes up. If you are an alcoholic, your triglycerides goes up. You take simple carbohydrates in large amounts, your triglycerides goes up. So now this is again the glycemic goals for a diabetic by different guidelines by American College of Endocrinologists and International Diabetic Federation and American Diabetic Association. You can see that there is a mild difference. It ranges from 70 to 30 or less than 110 and 115. And postprandial, it is more or less 140, 160 and 180, and HbA1c from 6.5 to 7. Now the glycemic control is most important. Let's say if a patient is a normal person or is into a medical intensive care unit or a surgical, the blood sugars in the fasting should be 90 to 126. This helps in reducing the mortality, infectious rates, and length of stay in the hospital. And the random should be less than 200. If a patient is the same thing, it reduces the mortality. And also we commonly see the sternal wound infections and wound dehiscence. The incidence can be lowered by having a very good glycemic target. Then in critically ill patients, again, we need to maintain 150 milligrams per deciliter. It again lowers the mortality, morbidity, and also the length of stay in hospital. In acute neurological disorders, it should be 80 to 140. There's not sufficient data available. So always ideal to keep the sugars under control. And this is by ADA and Society of Critical Care Medicine and American Heart Association and also Stroke Association. Now, this particular slide shows about the American Heart Association and as well as the Cardiology Foundation of America. So it says that a diabetic should have blood pressures of 130 by 80. It's an ideal thing, but it can be up to 140 by 90, few associations says, but try to have their blood sugars under control. This can happen by maintaining an ideal body weight, by taking a very good DASH diet, restricting salt, maintaining a good physical activity. And the blood lipids earlier, which I have addressed, the same thing, but it is again by American Diabetes Association. So in a gist, it is so that the HbA1c should be less than 7. The fasting should be 70 to 130. Postprandial should be 140 or 180. And blood pressures should be 130 by 80. LDL less than 100. HDL more than 40 for males and more than 50 for females, and triglycerides less than 150. Now, the most important thing is the BMI. Now, when it comes to Asians, we have large amounts of adiposity in the body. So the normal BMI for Asian Indians is 18.5 to 22.9. And the overweight category is 23 to 24.9. Pre-obese category is 25 to 22.9. And class 1 obesity is 30 to 34.9. And class 2 is 35 to 39.9. And more than 40 is your class 3 obesity, and less than 18.5 BMI is your underweight. So the BMI classification for the other parts of the world, the Caucasians or the rest part of the world is different. So the underweight is same, less than 18.5, but the normal weight is up to 24.9. And overweight is 29.9, and class 1 obesity is 34.9. And class 2 obesity is 39.9. We need to understand that because Asians has too much of adiposity, both central and upper body obesity, and they have less muscle content in their body, the obesity is 30 BMI for Asians. The most important and which is much neglected part is the waist circumference. So abdominal obesity is common in our Asian Indians. So it is a risk factor for hypertension, dyslipidemia, and dysglycemia. And if these are not under control, it leads to coronary artery disease. So ideally, maintaining a normal waist circumference and also waist hip ratio is most important. Now, the criteria for waist circumference is less than 70 for women and less than 80, then the risk is very low. If the waist circumference is 70 to 89, then they have low risk for women and 80 to 99 for men. And high risk is 90 to 109 for women and 100 to 120 for men. Very high risk is more than 110 and 120 for men. This is most important point to be addressed, that the waist circumference should be within the limits. Ideally less than 80 for women and less than 90 for men. Now moving on to gestational diabetes. So the diagnostic criteria is they should have fasting blood sugars approximately 95 and 1 hour post prandial glucose 140, 2 hours 120. Now the glycemic targets during the pregnancy by ACE and ADA guidelines is less than or equal to 95. And then postprandial should be less than 140 for 1 hour, 2 hours should be 120, and A1C target is less than 6. This is most important point to be understood because we have now the incidence of GDM mothers has been going high. If they have type 1 diabetes or pre-existing type 2 diabetes, they need to have the A1C of 3.4 to 5.5 millimoles. And postprandial, it should be 5.5 to 7.1 millimoles because they have been diabetic since days. So this particular target, little higher side is okay with them. Now, how do you manage gestational diabetes? What is the medical nutrition therapy? You have to provide them adequate calorie intake. Most of the dietitians do an error by cutting off their calories. This affects the growth of the fetus. So we need to have a adequate calorie intake, and you have to promote the maternal health, achieve the glycemic goals, which is most important. We cannot have fluctuating sugars, provide adequate gestational weight gain based on the current BMI of the mother, contributing for the fetus well-being. You have to prevent ketosis. If you starve the patient, if you restrict the carbs, they'll end up with ketosis. A minimum of 175 grams of carbohydrate is mandatory, at least 71 grams of protein, or additional 20 to 25 grams of protein according to their ideal body weight, and at least 28 to 30 grams of fiber is mandatory to keep the sugars under control. At least in our clinical practice, we try not to cut down more calories to maintain at least 18 to 2,500 kilocalories depending upon the height and the BMI. Too much of restriction leads to ketosis. Try not to have that scenario. Meal plan includes at least 3 small to moderate sized meals and 2 to 4 snacks. This prevents the crest and troughs of sugars which are maintained. Most important, the carbohydrate distribution. 40% of the total calories should come from the carbohydrates, 20% from protein, 40% from the fat. And because we have to give them good, healthy, essential fats. The fat content is high in gestational diabetes. The carbs are cut because they will be having erratic sugars post-lunch. So normal BMI calorie intake is 30 kilocalories per kg body weight. Overweight and obese, we have to give 20 to 25 kilocalories per kg body weight. Obese, that is more than 40 BMI, 12 to 14 kilocalories for the present pregnant weight. and we have to consume a minimum of 1800 kilocalories, which is really important. Underweight category of people should consume 35 to 40 kilocalories per day to achieve the recommended weight gain, to achieve the blood glucose goals, and to meet the nutrient intake. Splitting of breakfast into two halves, wait for an hour, check the glucose. Not possible. Is the slide show? You have to go down. Correct. Yes. I'm sorry for the technical glitch. So, protein to be more focused on include plant-based proteins as they are zero in cholesterol, multiple vitamins, minerals, which are really important in pregnancy. Try to incorporate low-fat dairy products if the mother is obese. If they maintain normal body weight, GDM mothers can take a normal percentage of milk, or milk should be an appropriate option. Fish and poultry are excellent source of protein. Fish to be more focused as it has got good fetal brain development. We need to cut down on the saturated fats. Focus that your saturated fat content is less than 7% of your calories and micrograms per day, and calcium 1200 milligrams per day. These are the nutrients to be focused in pregnancy, because the fetal development and the weight gain depends upon the serum iron and the HB level of the mother. The folic acid is essential for the neurological development, calcium for the skeletal development. Excuse me. I'm sorry. Non-calorie sweeteners, to some extent, sucralose, aspartame, and others are advisable in moderation, but it's always ideal to avoid them. Related to diabetes makes the patient outcome very bad. So now, what are the barriers you're unable to understand and deal with the diabetes is obesogenic environment. That means too much of addition of oil in the cooking, or very sedentary lifestyle, or eating outside foods frequently, taking calorie dense foods. So these are the sort of obesogenic environment. So we need to understand them and try to avoid. Lack of time for yourself to chalk a plan and go accordingly, and stress from external sources, because every Tom, Dick, Harry in India is a dietitian except me. So they keep proposing you so many diets. So you get carried away with them. So there's diabetes. Awareness is very less among the fleets between the advice and personal values used from somebody else, and totally that's the this is done. That is done. Next slide. So the ICMR recommendations: adoption of a diet containing varied nutrients, which is really important to keep the sugars under control. The carbohydrate should be 55 to 60%. It should include different kinds of cereals and millets, mixed coarse grains, whole grain pulses, salads, and soya beans. Protein, we have to contribute at least 10 to 15% from the vegetable sources. Low fat milk and milk products, fish and lean meat can be included. Fat should be 20 to 25%, comprising of less than 7% of saturated fats, and most of it, at least 10 to 12%, should come from MUFA, and 8 to 10% come from PUFA. The other recommendation includes consumption of moderate amounts of whole fruits and fiber-rich foods, restricted salt intake and artificial sweetness, and avoidance of alcohol and tobacco. This is Indian Council for Medical Research recommendation for diabetics. And if you see about Research Society and Study for Diabetes in India, RSSDI, this suggests that the carbohydrates can be from 45 to 65% of total calories, but can't be less than 30 grams per day of carbohydrate. A high fiber diet increase intake of soluble and insoluble fibers, include whole grain pulses, legumes, coarse grains, sprouts, unprocessed fruits, and vegetables. Most of us tend to take juices, canned fruits and vegetables. That is not entertained here. Substitution of polished white rice with millets and brown rice. Protein at least 10 to 15% of the total calories. American Diabetic Association suggests carbohydrates, high fiber, and focus on low glycemic index foods. And the preferred sources are fruit in moderation, vegetables in large amounts, whole grains, legumes, and dairy products, milk and yogurt to be focused for protein, calcium, and different types of micro and macronutrients. Protein should contribute at least 15 to 20% of the total calories, and patients having chronic kidney disease with diabetes should target about 0.8 grams of protein per kg body weight. Now, portion size is what is most important. When we talk about diet counseling, we say 1 cup, 1 handful. So the patient, for them to understand in a common way, for the diabetic educators even, or the bedside nurses in our absence, can do a small thing like this. So choose vegetables as much as that you can hold in your 2 hands. That's a simple thing like this. This much of vegetables should be there in your meal. And the chapati or rice or brown rice or a millets should be the handful. So it is something that a common layman even can understand. You need to have an alternative for meats like fish, poultry, and boiled eggs, or choose very lean cuts. And your fruit should be of a tennis ball size, and you should take milk and milk products or drink milk with or water with 250 ml. So this is how the portion size is very easy for them to understand. So this should be 1 teaspoon. This is 1 tablespoon. So the length of your thumb will tell you. So taking a meat of this size should help. Do not exceed the chicken, fish more than this size. So this is a table which shows about the glycemic index and the glycemic load of the foods. So the red color are really high in glycemic index and also load. So we have white bread, watermelon, popcorn, baked potatoes, and glucose ranges from 70 to 100. This is high in glycemic index. So if you incorporate foods which are high in glycemic index, then you will have very high sugars. And after taking that, within 1 to 2 hours, there will be drip in your glucose. So there's a crust and a trough of your sugars, which are really bad for your kidneys. So the green ones are low in glycemic index and load, like your peanuts, your beans, sprouts, your grapefruit, or the pizza is in low glycemic index. It doesn't mean that you have to eat pizza because of the cheese present in that. It is having low glycemic index. You can take your low fat yogurts, apples. You can also take a spaghetti is mentioned, which is again with a whole wheat, carrots, oranges, bananas, and potato chips, because they are oil fried. Oil will not allow the sugars to increase. It will keep the glycemic under control. But still, you need to understand potatoes, when they are fried, you have too much of saturated fats. So we also have something like medium glycemic index, your brown rice, your honey, oatmeal, ice cream, macaroni, raisins, white rice, and table sugar. So these are certain things we need to bear in mind about the glycemic index and take the foods accordingly. The most important thing for a diabetic is to include whole grain cereals and millets and keep rotating them. Do not refine them to a greater extent, like consumption of white rice. Since birth, we are used to eat 2 to 3 meals of rice, especially in South. If you prepare any breakfast item, it is pulihora, dadojanam, parmanam, paisam, everything goes with rice. We need to understand and change it to either a brown rice or millets gradually. As the pleasure of eating should be maintained, it should be happening with the portion control and also a variation in your cereals and millets. One thing we need to understand here, the millets are excellent source of fiber. They are low in glycemic index, glycemic load. They have multiple antioxidants, vitamins, and minerals. They relieves us from constipation. They keeps the sugars under control. They lower the cholesterol. They help in maintaining good blood pressures because of the potassium content, and also allows us to maintain the healthy body weight. But the size of your carb should be maintained. Whole grams and pulses, you can see the beautiful colorful picture of this pulses. Try to incorporate them as boiled grams or sprouts, or roast them, or prepare as a curry. So different types of antioxidants are present in them. Remember, cereals and millets may have some amount of antioxidant. Do process them in terms of wash and soak, drain the water, roast them, or cook them softly, or sprout them. This is how you can remove the anti-nutritional factors in any of the whole grain cereals and pulses. Seasonal vegetables adds to antioxidants, vitamins, minerals. Most of your carotenoids comes from your vegetables and fruits. Your zeaxanthin, xanthin, cryptozanthin, leucopene, all these lycopene, all these anti-nutritional factors are excellent in them. So try to incorporate at least half a kg or 500 grams of vegetables in the form of soup, salad, sabzi, and or raita or anything else. Fruit in moderation to be consumed, and try to avoid fruit juices or thick shakes or lassis. Try to eat sour to bland foods according to the seasons. If your sugars are better under control, take at least 100 to 150 grams of fruit every day. Root vegetables, these are a good source of water, antioxidants, good amounts of fiber, and they're excellent for weight reduction and also keeping the sugars under control. Beetroot and carrots should be taken less than 100 grams and do not exceed. Apart from that, onion, radish, nolkol, turnip can be taken in any amounts as they are excellent source of antioxidants. Choose low-fat dairy products for your buttermilk, curd, and milk, as they have less saturated fat and less amount of cholesterol, but provides us with calcium, phosphorus, riboflavin, protein, and vitamin A. Non-veg is excellent source of protein, vitamins, minerals, and antioxidants. Fish is an excellent source to reduce your LDL cholesterol, to improve your HDL cholesterol, and it is anti-atherogenic, anti-thrombotic, and it has got anti-inflammatory properties wherein the diabetes suffer from chronic inflammation. So at least 300 grams of fish is recommended by ADA and also by DASH diet. Eggs again are excellent source of multiple vitamins and minerals. Say any nutrient that is present in egg except vitamin C. So 2 to 3 eggs per week, including the yolk in boiled form, can be consumed. Skinless chicken in limited amounts in curry form is allowed. Lean meat cuts occasionally, monthly, twice or thrice, twice could be allowed in 75 grams. Nuts and oil seeds are excellent source of vitamins, minerals, omega-3 fatty acids, and also fiber. So gingerly seeds, our age-old traditional, is rich in calcium, iron, fiber, antioxidants, and omega-3 fatty acids. This can be included in the chutneys, curry powders, or in any other form. Handful of chia seeds, sunflower seeds, flax seeds, walnuts, and lentils, or any other nuts and oil seeds can be incorporated every day. Do not restrict nuts. They are excellent healthy fats. Have a hold on your cooking oil. This is only for the palatability, for the preparation. It can be cooked without oil even, but for the taste, limit your cooking oil to 3 to 4 teaspoons depending upon your body weight, and try to rotate the oils, incorporate different types of oils as they are deficit in nutrients like MUFA and PUFA. So if you have a varied consumption of oils, you will be compensating the deficit of the fatty acids. Sugar, honey, and jaggery plays no role in diabetes. It is always ideal to skip off this particular group of foods because they give you more of empty calories. Honey, yes, has some amounts of medicinal properties, but your other food groups also provide you good amounts of your nutrients. So occasionally during parties, a limited amounts of sweets or desserts can be consumed. Salt is a white poison. Limit salt. If you're hypertensive and diabetic, try to consume less than half a teaspoon of salt. No sauces, ketchups, papads, pickles, or table salt to be used because that is very bad. It leaches out the calcium from your bones. It weakens your cardiac muscle. It increases the blood pressure. It causes the sodium retention. So try to consume less salt and do not add salt in your batter dose of your breakfast items, your curd and buttermilk even. Points to remember: beware the years of bad choices, foods high in sugars, fats, empty calories, low in protein, fiber, vitamins, and minerals. Lack of physical activity or minimum exercise can result in stroke, heart disease, obesity, and different types of cancers, and also lowers your immunity. So ideally, Mr. Diet and Mrs. Physical Activity are key role for your healthy life. Thank you for your time and patient listening. Any queries I would take.
Thank you, ma'am, for giving a wonderful explanation regarding what to eat, when to eat, what type of food we need to eat, everything. If you have any question, you can post. Our expert will answering you. So we will go for a break for 10 minutes. Thank you. Next, we are going to see in hospital hypoglycemia and insulin management. For the same, I would like to invite Dr. Krishna Reddy sir. Sir did MBBS, MD, and DM in endocrinology. Sir achieved a lot of recognitions and awards, including gold medal in DM endocrinology. Dr. Krishna Reddy sir with us as a consultant endocrinologist with outstanding knowledge of endocrine problems. Over to you, sir, to share the knowledge of the topic in hospital hypoglycemia and insulin management.
Hey, very good afternoon, everyone. So, yeah, hi. Yeah. So, what is the insulin? What is the insulin? Yeah, so it's a hormone, right? So produced from the pancreatic beta cells. Okay, so which is very much essential to handle the carbohydrates in the body. Okay, as well as it also important in the lipid metabolism. Okay, so why we are celebrating November 14th as Diabetes Day? Any clues? What is the importance of November 14th? Today is the birthday of Banting. Okay, this is so he's a man. Okay, he's Banting. Okay, so before Banting, so many people have tried to isolate insulin from the dog pancreas and buffalo pancreas. So all those pancreases. So they know that there is some hormone which controls the glucose in the body. So before that, so many people with diabetes, they doesn't have any cure or any solution for the treatment of the diabetes. Okay. So 100 years back, so he's the doctor. He's actually basically an orthopedician. So he's the one who he made a method to isolate the insulin from the dog pancreas. So this is the dog they have isolated the insulin from. So behind he's a student. He's best. So with the help of his student, so he discovered the insulin. So this is a picture. So this is the patients before the invention of the insulin. So they used to be very cachexic and body cannot utilize the glucose as a fuel. Okay, so all the glucose will be lost in the urine. So this is what happens when the insulin is not in the body. Okay. So once they have started an insulin therapy, so they will become, insulin is an anabolic hormone. So uh, it will make the storage form of glucose and it will make the lipids from the even glucose and other things. So it will make the energy as a storage. So after that, the various forms of insulin has been isolated. So initially it is from the animal source. Okay. Later they have added some zinc and other proteinates of so other excipients to the insulin to prolong its action. So natural insulin has a very short duration of action. That is, if you use only regular insulin, that will act for only 6 hours. Okay, and an average. And if you add this NPH, that is neutral protamine hedgehog. Hedgehog is the scientist name. So protamine and zinc, if you add to the regular insulin, it will become the NPH insulin. So NPH is nothing but that cloudy part of the insulin. We are all be seeing that mixture, no? So that mixture is a mixture of regular insulin as well as the NPH insulin. Okay. So there is a cloudy part, so which has a prolonged action for almost more than or equal to 12 hours. And after that NPH, so a lot of innovation has been done. So one of the important milestone is in the 1970s, late 1970s and 1980s. So they have found out the recombinant human DNA insulin. So this is the first time they have made an human insulin. They have created through the recombinant DNA technology. Okay, from the E. coli. So they have injected the human insulin gene into the E. coli and they have started producing the human regular insulin. Before that, only animal insulins were available. Okay, so after that, there's a slight change in the composition of the human regular insulin. They have made a lot of changes to the insulins. Okay, so to make it more acting faster and more physiological, and some of the insulin they have added fatty acid to make the action for the prolonged periods. So they have made several changes to get our very rapid acting insulins as well as the very long acting insulins. So in the rapid acting insulins, the regular insulin, it has a biological properties. It onset of duration roughly around 45 minutes. Okay, 45 minutes to 1 hour. Regular human insulin. When you have injected subcutaneously, the onset of action will take some time. Okay, it won't go into the circulation. So that to overcome this problem, so they have made certain changes in the amino acid structure of the insulin to make it as a more rapid acting insulin. Okay. So for example, if you see Lispro, so they have made a positional change of lysine and proline. So the changes of lysine and proline has been reversed at B chain of the insulin structure. Okay. So there's a minor modifications which allowed the more rapid absorption after immediately after injection. So the onset of action will be within 15 minutes. So the insulin will start appearing in the blood. Okay. And another one is the insulin aspart. So they have just added an aspartic acid to the proline. They have replaced the proline with the aspart. And insulin glulysin, they have made two changes. One is at the B29 and B3, B chain. B means beta chain. A chain, B chain, two chains will be there. Okay. So with the slight modifications in the human regular insulin, they have able to achieve a fast onset of action and earlier peak and earlier disappearance of the action. Okay, so what are the advantages? We'll be seeing why we need to make so many changes to the insulin, why we are developing newer and newer insulin, what is the need, we'll be seeing. Okay. And in the long-acting insulins after NPH, they have invented a insulin glargine. Okay, glargine is nothing but they have added a aspargine, this two arginine molecules at the end of the B chain, and also they have made it more. This A chain also they have made a change in the aspargine to the glycine. So these are the two changes they have made. So which makes it the dissolution will be very slow. Okay, and more hexamer formation, and they will be slowly releasing into the blood. So the prolonged duration of the action, so almost up to more than or equal to 24 hours has been observed. Okay, and the insulin detimer, here they have added a fatty acid to the insulin molecule to prolong its duration of the action. So this fatty acid, when added to the insulin, so this made easy for the albumin binding in the blood. Okay, once this fatty acid insulin combination added to the albumin in the blood, so it will slowly dissociate from the albumin, and the duration of action will be prolonged for the several times. And one more in the latest one is the insulin degludec. So here they have added some more fatty acid. Here it is the 18 carbon fatty acid. The detimer, it is a 16 carbon fatty acid. So this adding the fatty acid have been prolonged the duration of the action. So almost it acts for 36 to 42 hours. Okay, once you have injected, that the insulin will be slowly released into the system and act up to 42 hours. And its half-life is being around 24.5 hours. And one more in the long-acting insulin is the insulin glargine U300. So initially that Lantus is there, no? So that is glargine. Okay, that is U100. That means each ml of that liquid will give rise to 100 international units of the glargine molecules. Okay, but latest is the glargine U300, that is Togio. Okay, it contains a highly dense particles of the glargine insulin. So because of the large, highly density packed insulin molecule, so when injected into the system, into the subcutaneously, so it will slowly reabsorb into the system. Okay, so it will more having a prolonged duration of action, almost more than 36 hours. Okay, so in glargine U300, you have each ml will contain 300 international units of the insulin. Okay. The latest insulin, they have even added this long-acting insulin with the rapid-acting insulins. Okay, like Mixtard. So this is the combination of newer generation of the insulins with the insulin aspart and the degludec. And after this, they have not stopped there. They're still trying to discover more and more latest generation of the insulin, which should physiologically mimic our glucose excursions in the body. Okay. Once you have taken food, immediately the glucose will start rising. Okay. And And if you have a delayed onset of insulin action, so there will be mismatch between your glucose excursions in the body and insulin absorption in the body. Okay. To match this profile, they are going into the newer and newer generations of the insulins. So one of the latest additions is the faster aspart, that is FIASP, okay, and the faster Lispro. So these are the two molecules. They have even far faster onset of action and earlier the peak and the early termination of the action, okay, which are essential to mimic the physiological glucose excursion after a meal, okay. Okay, so this is slide. Yeah, so this is a slide is important. Okay, so whenever you consume food, so this first blue line. So this is the normal physiological insulin secretion in the body. So once that glucose enters into your portal circulation, okay, through GIT, it will enter into the portal circulation and to the human pancreas. Okay, so once it enters the pancreatic beta cell, it will start producing the insulin. Okay, so this is how rapidly the insulin will appear in the body after once you have just having a thought of food or having a starting of the meal, the insulin will immediately start rising. Okay, so this is the first blue line is the normal, whatever normal people will have a that is the curve of the insulin secretion in the body. So immediately after food, it will start rising. So slowly, it will peak around 1 to 2 hours, and slowly the action will be waned off immediately. Okay. So if you give the regular human insulin, that is actrapid or lipinsin or vosulin or any R is regular insulin. Okay. So regular insulin is the recombinant human insulin that is discovered in the year 1980s. Okay. So when you have injected the regular insulin, the onset of action will be slightly delayed. Okay. So it will take 30 to 45 minutes to have an onset of action. Okay. And slowly the peak won't be equal to the normal endogenous insulin secretion. You see, this is the normal insulin secretion after a meal. Okay. But if you give actrapid, so this is the how it will absorbed into the absorbed into the system, and the action will be so much prolonged. Okay. Here there is no food actually. There is no glucose from the food, but still insulin action is continuing. Okay. In the initial stages, there is a hyperglycemia, but the action of the actrapid is delayed. Okay, so these are not the ideal insulins. And if you use the rapid acting insulins, so they will little bit better in mimicking the physiological insulin secretions. Okay, so they will start acting within 10 to 15 minutes, and the peak will be comparable with the normal insulin secretion in the body, and the action will also generally early it will taper off. Okay, and these are the ultra fast insulins we discussed, right? There's a FIASP and faster Lispro. So this is how they will act. So the onset of action within 5 minutes, and the peak is also more similar to the physiological insulin secretion. Okay, and the action of the insulin also terminates according to the physiological conditions. Okay, so this chart is important for you. So what insulins will act at how they will act. So if you see the regular insulin, the onset of duration is 30 to 60 minutes. Some of the patients, each individual's insulin absorption is different. Okay, so you should see based on their meal excursions and pre-meal, hyper and hyperglycemia fluctuations. Okay, so some of the people they have a onset of within 30 minutes, and some they may have 1 hour delays also. Okay, so that's why you need to give at least 30 minutes before meal this insulin, regular insulin. Okay. Otherwise, it won't match with your post-meal glucose excursions. Okay. So there will be mismatch. We have seen in the previous class, right? So there will be mismatch if you won't give at least 30 minutes prior to the meal. Okay. So ideally, I have to give them insulin, wait for 30 minutes, then you should start eating. Then only the insulin curves and the glucose excursion curves will be parallel. Okay, and the peak will be around 2 to 3 hours. Uh, is a somewhat delayed than physiological one, and the duration of action is also varies between person to person. Okay, so you should be very careful, and if any pre-meal hypoglycemia, any patient experiencing, so they may have a longer duration of actions. And coming to the rapid acting insulins, they will have an onset within 5 to 15 minutes. So that's why we advise to take just to be for 5 minutes before meal, this insulin aspart we will advise to take. Okay. And the peak will be around 1 to 2 hours, and the duration of action will be short-lived. That is only 4 to 6 hours. They will appear in the blood. After that, they will vanish off. The effect of insulin will be gone. Okay. And the faster acting, so there will be more physiological in nature. The faster onset and earlier the peak, and earlier the decrease in the duration of the action. And in the basal insulins, we have NPH insulin. Okay, so we generally rarely give individual NPH insulin, that is insulatard or insulin N. Anything comes as a N, that is the NPH insulin. Okay, so we generally use nowadays. We use as a part of mixture, mixing the both this regular insulin and NPH insulin. Okay, so the duration of action of this NPH insulin up to 12 to 18 hours. If you give one injection now, so at 8 o'clock in the morning, it will act up to 8 o'clock in the evening. So that's why these basal insulins of NPH, we generally give 2 times a day, 8 o'clock in the morning and 8 o'clock in the evening. Okay, and but unfortunately, this NPH insulin has a peak. Okay, so we expect a basal secretion of insulin to be a constant one. Okay, there should not be any fluctuations. Okay, so to have a proper correction of the hyperglycemia, we need a continuous basal insulin supply, and postprandially after eating, the glucose excursions will be very much high. So to cover that, we need to give the prandial insulins. Okay, so the prandial insulins will be short-acting insulins. For the basal insulins, we have a choice of NPH and this glargine U300, that is Lantus or Desaglar, or Detimer and Degludec, that is Tresiba, okay, or glargine U300, that is Toujeo, okay. So for a continuous insulin supply, we need to give for 24 hours, we need to give an long-acting agent, okay. To cover the post-meal glucose excursion, we need a shorter acting insulins like rapid acting insulins. Okay, so in the basal insulins, we have NPH and Detimer and this Lantus. So Lantus doesn't have somewhat less peak, and it will act for the 24 hours. Okay, so for example, if you give a 60 units of Lantus, this 60 units will be slowly released over 24 hours. Okay, but if you give a 60 units of Actopid, it will immediately it will release into the system within 6 hours. Okay, so per hour, almost 10 units of Actopid will go into the system. Unlike in the long-acting agents, so they will have a stable insulin release slowly into the system, so that insulin secretion will be prolonged. Okay, so the risk of hypoglycemia is also a little bit lesser with the basal insulins. Okay, and Degludec that will act for more than 42 hours, and U300 also acts for more than 36 hours. Okay. Okay, so there is a universal color coding system for each insulin. Okay, so if you see that regular insulin vial should be always that yellow tag will be there. Okay, so this is how they will identify the component of insulin if the label is gone. Okay, so NPH insulin will be green in color. Okay, and the mixtard will be brown in color. Okay, this pre-mixed insulin, this is the mixtard. So this will be brown in color. Okay, and insulin glargine will be purple. Lantus will be in the purple color, and this levimir detimer is the dark green color. Okay, so these are the some of the colors. Like insulin aspart, that is Nova Rapid. Okay, so that novorapid will be in the orange color. Okay, so different insulin components have different color coding system that is universally accepted. Okay. So how to manage the in-hospital hyperglycemias? Okay, so we'll be seeing so many patients with diabetes in our wards and in admissions. Okay, so almost 50% of our hospital admissions due to various reasons, they'll be having diabetes. Okay, so to have a proper control of sugars is very, very important to have a less risk for the ICU admissions, less risk for the prolonged stay. Okay, less risk of infections and everything. Okay, so you need to have a proper glycemic control in the in-hospital admission patients. So there are various barriers to achieve in this glycemic control. Okay, so hyperglycemia is related to the mortality. Higher the glycemia, especially in the COVID patients, we have all seen that higher the glycemia, higher will be the risk of ICU, MICU admission, higher will be the risk of death, higher will be the prolonged ventilation, so everything. Okay, so you need to have a proper glycemia. So without, because of the larger fluctuations in the sugar will lead to larger inflammatory cascade. Okay, so there will be a lot of inflammation will be going on if the sugars are getting fluctuated. Okay. So the glycemic variability, that is the fluctuations in the sugars, and hyperglycemia. Variability means nothing but the sugar going up to 60 and going up to 300s and coming to 60s and again going back to 250 and again coming to 100. So these fluctuations will lead to the higher organ damages. Okay. So, and higher glycemic variability and hyperglycemia. So both are dangerous. Both will increase the risk of sepsis and mortality. Okay, so how to manage this hyperglycemia in hospital setting? So OAD is actually not recommended. So because most of the patients in the hospitals, they will be having a lot of stress, and the dynamic nature of the food is also very much changed. Okay. For example, if the patient NBM today, by evening on the liquid diets, and the next day they will go into solid diets, and the one more day they will be having vomiting. Okay, so the constantly dynamic scenarios will be there in the wards. Okay, so that's why OADs, they will have a unique mechanism of action. They will require almost 1 to 2 weeks for the titration. Okay. So if you give a tablet and you want to titrate dose, titration of the dose or decrease down titration of the dose, so it will be very, very difficult with the oral anti-diabetic agents. So that's why insulins are the preferred agents in maintaining of the in-hospital hyperglycemias. Okay. So out of that, we have IV insulin infusions, especially who is not taking anything orally on ventilations or in ICU setups. Okay, and all patients who are able to eat orally, and they ideally should be taken subcutaneous insulins. Okay. So what are the targets we generally keep for in-hospital hospitalized patients? So we try to target between 140 to 180. Okay, so this is a better way. So many studies are showing. So hypoglycemia and hyperglycemia, both are dangerous. Okay, so sugars are going below 70 is also dangerous, and sugars are going beyond 220 is also dangerous. Okay, so to prevent that, so we put a target between 140 to 180 to have an edge. So we try to prevent as far as possible hypoglycemias at any cost. Okay, so these are the different societies has given different targets. Okay, so we generally tend to if the stable patient, ward patients, we try to have a target of fasting glucose of 110 to 140, and the rest all meals it should be below 180. Okay, so that is the better way of managing. Okay. And any patient who is not taking anything orally and poor oral intake is there, so we generally initiate on basal insulins once a day, so which will act for the 24 hours. Okay, And we monitor sugars every 8th hourly or 6th hourly, depend on the need. And this 6th hourly correction doses can be given, okay, with the short acting insulins, okay. And if the patient is taking orally and is a normal patient, the ideal way of treating him is the basal insulin for the basal core of insulins, and prandial insulin, that is post to avoid the post meal excursions. We will give this short acting insulin along with the corrected doses, okay. So to check previous meal dose, previous before lunch or before dinner, what is the sugar value and what is the usual requirement of the meal insulin, plus how much excessive glucose is there, what is the correction factor. So we'll add this prandial insulin with the correction factor and we'll give the dose, okay. And sliding scale is strongly discouraged, okay. So why, we'll see. See, if you see that basal bolus regimen, that is having a basal insulin with the prandial insulin covering the prandial needs, versus a sliding scale. Sliding scale is nothing but this much of glucose, this much of insulin, okay. So what happens? So if the patient is on sliding scale, if the sugar is 100 or 140, we won't give anything. So after the taking a meal, the sugar will shoot up to 300. Okay. Again, you give the insulin at that point of time. Again, the sugars will come down to 100 or 140, and again you won't give any insulin. So this is a roller coaster effect. Okay. Sugars are going up and going down, going up, going down. So this will create a lot of inflammation in the body. Okay. So which causes the organ damage. Okay. So this is a roller coaster effect we see with the sliding scales. Okay. And this sliding scale is also this each individual have a different insulin resistance. Okay. Some of the patients will be very, very insulin sensitive, and with 2 units of insulin only, they will come down to normal levels. Okay. But some of the patients, if you give even 15, 16 units of insulin also, according to sliding scale, it is very difficult to titrate. Okay. So, but if you initiate on patient on both basal insulin as well as 3 prandial insulin, so nicely after 3 to 4 days, 3 to 4 days of the basal bolus regimen, that sugars will slightly come back to the norm. This is the sliding scale. 240 given insulin came down, and again shooted up and given sliding scale came down. Okay, so for 4 days there was a lot of fluctuations in the sugar. Once this patient has been started on basal bolus regimen, the sugars are slowly fallen from to the normal range, that is up to 120 to 140, the fasting levels. Okay. So it basal bolus has 3 components. One is the basal insulin to cover the fasting needs of the insulins. Okay, so everybody needs insulin to suppress the lipolysis and other metabolic activities. And bolus insulin means that is to cover your meal related excursions in the sugars, and correction doses, because a lot of stress and a lot of fluctuations in the even some patients on other steroids or anything. So there will be a lot of fluctuations in the blood sugars. Okay. If the pre-meal sugars are around 250, so we'll add along with the basal and bolus, we'll add some correction insulin to the bolus component to have to bring it back to the 140. Okay. Okay, so the insulin dose will be calculated based on so many methods. Okay, so this is one of the method. If the patient is underweight, so we try to start around 0.3 units per kg per day, which includes 50% of the basal insulin and 50% will be prandial insulins. And if the patient having a normal weight and normal insulin resistance, 0.4 units per kg, and overweight individuals, 0.5 units per kg. And if the patient is obese and so much insulin resistance, and is the patient is on glucocorticoid medications, so we generally keep more than 0.6 units per kg. Okay, and this is the correction scale. So after deciding the total insulin per day, that is roughly around 0.5 units per kg per day. So if a 60 kg male is there, normal weight, normally built, so we give around 30 units per day. Okay, in that 30 units, 15 units of a Lantus and 5 units of the Actropid. Okay, and if the pre-meal sugar is around 250, okay, so like 250, and the pre-meal sugar is 250. Like here, this is the line he is falling in. Okay, the 250 and is a normally built, is not a overweight or not a thin individual. Okay, so the correction dose is 8 units. Okay, to that 5 units of prandial, that bolus insulin, will add 8 units, so 13 units of Actopid at that point of time, for that meal. Okay, so again we'll check it at the pre-dinner. The still sugars are around 200. Then again we'll give a correction unit of 6 units to 5 units of the Actopid. Okay, so that comes to around 11 units of the Actopid. So that's how we generally do. Okay. So the longer generation insulins, that basal insulins, will have very less fluctuations in the glycemic control. Okay, to cover, if you cover the basal insulin, then the fluctuations will be very, very less. Okay. And with the newer generation of insulin, the handling the sugars are very, very convenient and easy. Okay. The risk of hypoglycemia is also very less because they will match with the endogenous glucose production and the prolonged duration of the action with the basal. So the risk of hypoglycemia is also minimized. Okay. Yeah. Any doubts? You will be managing lot of diabetic patients in the wards, right? So any doubts in the thing?
Any doubts? Okay, as we all are nurses, we have to be very careful when you are administering insulin. It will be according to the type of the insulin which will be acting. So I think all are in hyperglycemia. Okay. So if you have any doubts, you can post in chat box. So our experts, doctors, everybody will be answering you. So next we can take a lunch break of half an hour. Thank you all.
you, sir.
Good afternoon, sir. Myself Ramya from MICU. I have a query regarding nowadays we are giving the Lantus to the patient injection. What is the duration and how does it act? Difference between the insulin, human atropine and Lantus.
So actually, this we are saying that the best way of giving insulin is the basal bolus plus correction doses, right? So we need to add. So this in the basal insulins we have NPH, glargine, and Detimer and Degludec and Toujeo U300. Okay. So this Lantus will have a slow release of action to cover your fasting needs and basal needs. Okay. The patient is not taking anything orally, and so they require only basal insulin. Okay. So just one shot of basal insulin, and in between correctional insulins can be given. Okay. So no food means no need of any prandial or bolus injections. So these patients should be on ventilator or any patient. We generally give a basal insulin which acts for the 24 hours or more than 24 hours. Okay. This actropid insulin is the prandial insulin. Okay. So prandial means that to cover your post meal excursions in the glucose. Okay. So they will be short acting. So they will they will cover the needs of the meal and they will immediately vein off from the blood. Okay. Okay. Yes. Liver.
End-stage liver disease.
Liver disease.
Yeah,
Okay.
they are very catabolic, malnourished. They don't eat adequate food.
Yeah.
So if they are diabetic, how do you manage them?
So generally, end-stage liver, the options for the medication is very, very less, oral medication. Okay. So especially we can give some linagliptin, lower doses of the sitagliptin at the max. Okay. So majority of the time, so these liver disease, liver is major important organ from the gluconeogenesis. Okay. So our brain needs continuous glucose supply. Okay. So even in the fasting status also we need some glucose production in the body. Okay. So this can be achieved from the stored glycogen breakdown or lipid breakdown. So these will be converted to the glucose in the fasting status. Okay. So liver is the important major site for this gluconeogenesis that will maintain the glucose in the fasting status. Okay. So when there is a liver issues, the glucose won't be contributed from the liver to the system. Okay. So these are the patients, particularly they will go into the hypoglycemias whenever they do the fasting. Okay. So that's why we generally try to, treat them with the shorter acting insulins as they only further to cover the meal related excursions in the sugars. Okay. So based on the patient profile, we can prefer either a rapid acting or even if the patient is not affordable, just a 3 meal actropid is sufficient for them.
Sir, one more query. During we will be taking the patient for the PET scan. The sugars should be only 180. The range is only 180. If the patient is having more than 180, why we should not give insulin to the patient and why?
Okay. So the PET-CT is nothing but it's a 18F glucose. Okay. So they will use a glucose in the PET-CT scan. Okay. So when there is a higher glucose, so that will interfere with the scan. Okay. So if you give insulin immediately, and this insulin will create the GLUT4 receptors in the muscle and liver and adipose tissues. Okay. So wherever the insulin end organs are there, so it will increase the expression of the glucose consumption of the receptors. Okay. So that will detect as a higher metabolic areas in the PET-CT scan. Okay. So that's the reason why. So we should not have a higher amount of insulin in the system. At the same time, higher sugar should not be there. Okay. Yeah, that's better. Before bed night, if you give a long-acting agent to bring down this fasting sugars, that is the ideal way to go for a PET-CT scan. Hmm.
How we have to titrate insulin and what kind of nursing interventions. I have seen many cases patients into hypoglycemia change.
Oh.
How we have to titrate.
Yeah, whenever some of the chemotherapeutic agents, especially which contain the glucocorticoids, steroids, so which are actually they will kill the beta cells. Okay, the insulin production will be comes down naturally. Okay, so these are the patients who are prone for the higher fluctuations in the sugars. Okay, so in those scenarios, we generally give more of prandial insulins and lesser dose of the long-acting insulins. Okay, and this food intake will be also dynamically changed. Okay, so that's why we should have a not only just to depend on the regular insulin, we should cover the basal part of the insulins with the long-acting agents. And based on the sugar levels, we can give either correction doses, and if the patient is taking, you can give the bolus doses also. Mhm. Yeah, so different patients based on their insulin sensitivity, some may go rapidly, they are very sensitive, they will go into immediately hypoglycemia. Okay, so based on the sensitivity only, we generally tend to give the insulin doses. Okay, as far as possible, hypoglycemia is far more dangerous than the hyperglycemia. So we try to avoid the hypoglycemias. And regarding monitoring, if the patient is having a hypoglycemia previously, we try to monitor more frequently. For example, if the patient is having hypoglycemias, we see before breakfast, 2 hours after breakfast sugars, before lunch, 2 hours after lunch, and before dinner, 2 hours after dinner, and one at the bedtime, one at the midnight, 2 o'clock. So this is called a 7-point GRBS profile. So based on the, if example, type 1 diabetic patients, so they are more prone for the hypoglycemia because they doesn't have any insulin production in the body. Okay. So the same patient having a brittle and hypoglycemia, we try to give a 7-point profile of the GRBS. So based on that, we can adjust the insulin doses. Diabetic insipidus. Okay. So we generally, if the patient is conscious, there is no need to give anything. Okay. If he has a good access to the water, he can take as much as water based on his thirst center stimulation. He need to have a good access to the water. So there is a, yeah. So those patients we generally treat with the desmopressin tablets. We should be very careful. If you are starting on desmopressin, so which has a anti-diuretic action, so at that point of time, so if you give a more free water, they will go into the hyponatremia. Okay, so it should be ideally you should be replacing the urine output along with the insensible water losses. You should be and you should be giving the urine. And if the patient is not on desmopressin, ideally you should you should replace the urine output and insensible water. Yes, yes, yes. No, so serum osmolarity, the major ion is the sodium. Usually they will go hand in hand. So especially when there is a hyperosmotic status like high diabetes, or whenever you are giving mannitol or any glycerol or anything, so high osmolas, then maybe some mismatches between the sodium and the this. Yeah, yeah. So that may lead to some problems in the thing. So for that hyperglycemia related sodium, we'll have a correction formulas, whether it is a hyponatremia or pseudo hyponatremia. So based on that, we can take call. Newborn babies, we won't give half NS and like that. We generally treat with the 10% dextrose. Okay, so their need for the dextrose is very high. Okay, so instead of 5%, we try to give it maintenance with the 10% dextrose. And if required, if any hypoglycemia is there, we give around 4 to 6 milligrams per kg per minute of glucose. Okay, so there is a general basal requirement for the glucose for the brain. Okay, the brain will be highly metabolic organ, which continuous supply of glucose is needed. So around 4 to 6 mg. So based on the need, we may further titrate up to 12.5 mg per kg per minute. Still, the patient is not able to tolerate. We may use other therapies like glucocorticoids and other agents. Isolate P is not using, but the half DNS they are using as a maintenance therapy, but not as a hypoglycemia management. They can use half DNS, no problem.
So thank you so much, sir, for your valuable time. Still, half-line audience, you have opportunity to post your questions in chat box. Our speakers are ready to answer till end of the day. Session is open for till 5 o'clock. Even further also, we are ready to accept your questions. So freely post your questionnaires in chat box, YouTube viewers and Zoom link viewers. You have every right to post your questions. So thank you so much, sir, for your valuable time. Now I can break for lunch break. Okay, now time is 1:45. Please try to assemble by 2:15. Next eminent speaker is waiting for us. So please try to be in time because we are already lagging a half an hour back. So try to come by 2:15, gather over here. So break for lunch session. Thank you so much. Thank you, sir.
Start the slide. Here it is also visible, no?
Good afternoon, all. Had your lunch? Shall we start the session? Now, we are going to see the topic of pre-diabetes. It is by Dr. Midil B. Goucher. Sir is a consultant general physician, MBS MD in internal medicine. Sir has an experience of 8 years in this field. Dr. Midil B. Goucher practices at medical hospitals in Secunderabad and Hyderabad. Sir completed MBBS from Maharashtra University of Health Science, Nasik, and MD in internal medicine from Maharashtra University. PG diploma in diabetes from Johns Hopkins University, USA in 2014. Sir achieved many recognitions and awards. I'd like to invite Dr. Midil sir for presenting the topic of pre-diabetes. Over to you, sir.
Thank you. There is just one correction in your intro. That is old intro. Now my experience is now 15 years. Okay. Let's see today's topic, pre-diabetes. Okay. So on World Diabetic Day, why would take the topic of pre-diabetes? See, this pre-diabetes means stage before diabetes. So don't let that pre fool you. So I took the picture of this slide because this is the man who is having pre-diabetes. He's on the road pathway of diabetes, and there you can see the U-turn is there. So how we can take the U-turn? Let's see all that thing in today's session. So today's agenda will be introduction, pathophysiology, symptoms, diagnosis, complication of pre-diabetes, and how to undo pre-diabetes. That is the treatment part. So let's see introduction. So what is pre-diabetes? So pre-diabetes is a serious health condition where your blood sugar level is more than normal, but not high enough to be called as diabetes. So it's a stage in between normal and diabetes. So why we choose this pre-diabetes topic? Because in the recent past, there is a link association between cardiovascular disease and pre-diabetes, and the recent study shows that patient develops coronary artery disease and diastolic heart failure. Even patient develops before converting into the overt diabetes.
So that is the reason why we choose the pre-diabetes as a topic. So pre-diabetes, the blood sugar is higher than normal, but not high enough to be called as diabetes. So what is the magnitude of this pre-diabetes? What data says? So this is the International Diabetic Federation data. So in 2017, the prevalence was 7.3, and in 2045, it is expected to be 8.3. So at present, worldwide, there are 352 millions of pre-diabetics are there. That's a huge number. And in 2045, it is expected to be 531 million. So these are the latest data according to International Diabetic Federation, where India is in the fourth position. It's showing 24 million, and in 2045 it is expected to be 41 million. But this international data not correlate with our data. So what Indian data says? See, in US, according to Center of Disease Control and Prevention, about 84 millions adults in the US have pre-diabetes, and most of them will be converted into diabetic over a long term of time. So this is the Indian data. The first study was done in the Chennai urban population study. It is published in 2008, where the incidence was 13.1. They followed this study for another 8 years, and they found that conversion of pre-diabetes to diabetes was 40% in 8 year time. In 10-year follow-up with Chennai urban rural epidemiological studies, found that rate to be whooping 29.5 per 1000 per year. So in 2017, the study ICMR India, a large multicentric cross-sectional study was done in 15 states of India, where it has documented high prevalence of pre-diabetes compared to diabetes. It was 24.7%. This was the study. And they found that in 2011, the pre-diabetic were 77.2 million. So at present, India have 80 millions of pre-diabetics. So this is the America's data. They have 86 millions of Americans are pre-diabetic. 1 out of 3 patients are pre-diabetic, and nine out of 10 don't know they have pre-diabetic. So this is the alarming thing. So this is the thing in the educated country like America. So you can understand in our India what is the situation will be. So let's see pathophysiology. So in pre-diabetes, the insulin resistance happens, and impaired insulin secretion, increased lipolysis, and dysregulated hepatic glucose production leads to hyperglycemia. This is the simple chart where you can see insulin is the key, and the cell there is a lock is there. So that insulin is required. That key is required to let the glucose go into the cell. That is the normal thing. But in the next slide, you can see when there is insulin resistance is there, that glucose can't go into the cell, and there is a hyperglycemia is there in the blood. So what happened in the case of pre-diabetes? There is a loss of beta cell functions occur before diagnosis. You'll surprised to know that this in pre-diabetes, 50% beta cell function is lost at the diagnosis of pre-diabetes. So this is the natural history of diabetes mellitus, obesity, pre-diabetes, diabetes, and uncontrolled hyperglycemia. So every patient, they will pass through this stage. So pre-diabetes, and every diabetic patient will pass through this stage: obesity, pre-diabetes, diabetes, and hyperglycemia. The exact cause of the pre-diabetes is not known. It is suggested that family history, genetic predisposition, and associated with increased BMI, obesity, and sedentary lifestyle, they contribute to the pre-diabetes. This is the natural history of pre-diabetes, where you can see after 10 years, if someone is diagnosed with pre-diabetes, and after 10 years, they're converted into type 2 DM. 50% of them are converted into type 2 DM. This is the natural progression of prediabetes. So how to diagnose the prediabetes? This is the ADA 2021 guidelines is there. So you can diagnose prediabetes by simply three ways. You can check your fasting blood sugar. You should be fasted for 8 hours at least. So if your fasting blood sugar is between 100 to 125, you are pre-diabetic. If your HbA1c level is between 5.7 to 6.4, you are pre-diabetic. And after 2 hours 75-gram glucose tolerance test, if your sugar is between 140 to 199, you are pre-diabetic. And for all these three tests, risk is continuous, extending below the lower limit of the range and becoming disproportionately greater at the higher end of range. Means if someone is having X is having HbA1c is 5.7 and Y is having HbA1c of 6.3. So Y is at more risk in the future to develop to convert into diabetes. So now we know how to diagnose. What are the symptoms of pre-diabetes? Actually, there is no symptom. It is asymptomatic state. That's why it has to be detected through screening only. There is because there is no symptom. Once you have polyuria, polydipsia, polyphagia, means you are converted into diabetic stage. For pre-diabetes, there is no symptom. It is asymptomatic. So how to screen it? So AD has given the recommendation. Any person with overweight, obesity, BMI more than 25. For Asian, they have lower the value. It is for 23. And one who is having overweight and obesity, plus they have additional risk factor, then they should go for screening of pre-diabetes. Another condition in women with overweight or obesity, planning pregnancy. If you are not obese, overweight, then or you don't have any risk factor, then the testing should begin at the age of 45 years. So what are the risk factors? Now you are obese, and if you have any of this risk factor, you should go for the testing. So older age group, obesity, overweight, male gender, male is more, they have more chances of developing this. Any family history of diabetes mellitus, history of cardiovascular disease, elevated blood pressure, or if you are taking any BP tablet, low HDL level, if it is below 35, or your triglyceride levels are more than 250, smoking, alcoholism, physical inactivity, sedentary lifestyle, or clinical marker of insulin resistance, like acanthosis nigricans, woman who has the history of GDM, gestational diabetes mellitus, or polycystic ovarian syndrome. If you have any of this risk factor and you are obese, overweight, or your BMI is more than 25, you should go for the test. So this ADA has given simple chart for the pre-diabetes risk assessment. So they have given this 7 things. One first is what is your age? According to age, you should give your point. Then gender, sex, man or woman. Man 1 point, woman 0. If you are a woman and if you have history of gestational diabetes, 1 point. Then family history. Then BP, high BP. If you are high BP, 1 point. If you are physically active, 0. Not active, 1 point. And your weight status, you can see their weight status. So according to your height and weight, and just give point on that basis. So if your score is more than 5, then you should go for the test. So India also developed their own scoring system. That is Indian diabetic risk scoring. So they have taken 4 factors in account: age, abdominal obesity, physical activity, and family history. So if your age is more than 50, score is 30. That is abdominal obesity, waist circumference. If it is more than 90 for female and more than 100 for male, 20. Physical activity and family history. If your both parents are diabetic, then 20 points. So maximum score is 100, minimum score is 0. So if your score is more than 60, there is a high risk for diabetes. 30 to 50 is a moderate, and below 30 is minimal chances. So what they did, they found that limiting blood sugar testing to those who has a score of 50 and above, we can find out 90% of Indians with diabetes and pre-diabetes. No, now coming to this thing, Indian diabetes risk scoring, whether we require this scoring or not, actually we do require this scoring system because India, you know, it's a poor resource setting country. So, and we have largest diabetic pool and pre-diabetic pool. And compared to West, we have less diagnosis of diabetes and pre-diabetes. So, to actually find out how many patients are affected, to find out the hidden burden of this disease, we should use this Indian scoring, diabetic risk scoring, because it's a simple device, simple testing is there. So now why to diagnose pre-diabetes? Because I said earlier also, it is associated with cardiovascular risk factor. So let's say complication. This is a complication of, at the diagnosis of pre-diabetes, you can have microvascular complication and macrovascular complication. So microvascular complication are nephropathy, neuropathy, retinopathy, and macro is cardiovascular disease, cerebrovascular disease, peripheral vascular disease, and type 2 DM. We'll convert into that. Dyslipidemia and prediabetes are also associated. High HDL-C level is associated with increased probability of the prediabetes. And this is the hypertension and prediabetes. If you see the hypertension and prediabetes, your risk is increased. You can see it in cardiovascular disease, in impaired glucose response, the rate is around 10.53%. This is in the next slide. So this is the data from the 53 prospective cohort studies where 16 lakh people are examined, and they found that CVD risk is increased by 13% in pre-diabetes, 10% in coronary artery disease, 6% stroke, and the last column you see all-cause mortality increased by 13%. So that the famous line is there. Your clock start ticking from this stage only, pre-diabetes. These are the slides showing the microvascular complication of pre-diabetes compared to placebo. This is the macrovascular disease. Green one is pre-diabetes and blue is placebo. And they also observed CV mortality benefit is seen in if pre-diabetes is undone. As pre-diabetes was reversed, there was also reduction in CV mortality and morbidity when mainly 2-hour plasma glucose is brought to normal levels. So now how to undo pre-diabetes? That is our topic, what we are discussing this thing. So there are two important aspects of prevention of diabetes, pre-diabetes. One is lifestyle intervention. That is the most important cornerstone modality of this treatment. And another is the drug. So let's see one by one. These are the non-modifiable risk factors. So age, sex, gender, family history, you can't modify that thing. So modifiable risk factor is physical inactivity, obesity, hypertension, smoking, lipid metabolism, and high plasma glucose. So you need to treat for blood pressure. If you are dyslipidemia, that you should be treated for that part. The study done in the 2015 in the Sleep Journal shows that if you don't have proper sleep for 8 hours, then your risk of pre-diabetes is increased. So 8 hours sleep is must. So what ADA has given lifestyle modification to undo pre-diabetes? You should lose your 7% of initial weight. So if suppose someone has 80 kilo weight, 80 kg weight, they should reduce 5.5 kg and you should maintain that weight. Exercise, 150 minutes per week of moderate exercise is required. For diet, they have not given any specific recommendation, only intensive behavior management to achieve that 7% weight. There is no specific diet they have advised. So exercise program, 150 minutes per week of moderate intensity aerobic activity. So what do you mean by moderate intensity? So moderate intensity means 50 to 70% of maximal heart rate. So if how to calculate that one? If someone is at the age of 40 years, so you have to calculate 220 minus 40. So that is for male. For female, 226 minus age. So if someone is 40, so 220 minus 40 is 180 is their maximal heart rate. So 50 to 70% means 90 to 126. So whenever they are walking, their heart rate should be around that range, 90 to 126, between that range. That is called as moderate intensity aerobic activity. So brisk walking is the most simple thing. You can do running, jogging, swimming, whatever aerobic activity you want to do. So brisk walking is most simple. So what is brisk walking? Brisk walking means 100 steps per minute, or you should cover at least 6.5 kilometer in 1 hour. That is called as brisk walking. Another test is talk test. So while brisk walking, you can have normal conversation, but you can't sing. That is the another way to see whether you are walking brisk or not. And it has to be done over a period of 5 days a week. No more than 2 consecutive days should be off. Resistant training has to be done at least 2 times a week. And breaking up a prolonged sedentary time that has to be encouraged. Means don't sit for prolonged time. At least take a walk or a move. That is very important because it associated with moderately lower postprandial glucose level. So because of lifestyle modification, physical activity, your insulin sensitivity is improved. There is improvement in the lipid level, blood pressure lowers, weight control happens, improves the blood glucose level, that's thereby reducing the risk of cardiovascular disease. So nutrition part. So this is the, you should reduce your calorie intake by 500 to 1000 depending on how much weight loss you want. Reduce your total dietary fat, refined and processed food, limit intake of sugar, sweet beverages. Dietary fiber intake should be 14 grams per 1000 kilocalorie. Whole grains are 50% of total intake. Vegetarian plant-based diet, DASH diet. DASH means dietary approach to stop hypertension. This diet are associated with lower risk of diabetes. Because I told you, because the ADA has not given particular specific recommendation for diet. It is just you should lose 7% of your weight, total weight. So whatever the macronutrient you want, you can take it according to your diet plan. So there is another way. There is a plate method. It is a 9-inch dinner plate. So it has to be divided into half, and the half portion has to be divided further into half. So 3/4. So in 1/4, protein should be there, like chicken, fish, egg, tofu, paneer. You can take that one in the protein section. This is non-starchy vegetable. It has to be filled in half plate. That is spinach, carrot, lettuce, green cabbage, green beans, broccoli, cauliflower, tomato, okra, mushroom. These are see, basically these two groups, protein and non-starchy. They are having less glycemic index. So the one glycemic index is below 50 is what we preferred for diabetic patient, pre-diabetic patient. So this group belong to that low glycemic index. And this is the high index, high glycemic index group. That is because we require energy also. So grains and starchy food, whole grain, bread, rice will come into this section. So now this ADA has formulated, this recommendation has been given 7% of loss of weight. So where it came from? This data recommendation all came from this trial, DPP trial. This is the landmark trial for diabetic prevention program trial. It is done in USA. So they followed the patient for 2.8 years, where one group was kept in control and one group has a lifestyle intensive lifestyle modification, where 7% weight loss and 150-minute per week exercise was done. So they found that 58% reduction in the intensive lifestyle group, and the one in the with the metformin group, they found it 31% less reduction in the diabetics incidence. And as the age advanced, they found there is a further reduction in the diabetic conversion of to into pre-diabetic to diabetic, 71%. There is another study, Finnish diabetic prevention study. It is the first study that was done for diabetic prevention. They also found similar results. There is a 58% reduction in the lifestyle modification group. And they also found the improvement in other parameters, blood pressure, uh, systolic and diastolic pressure improved with the lifestyle maneuver. The fasting and 2-hour insulin also improved with the lifestyle intervention. This is the another study, Chinese trial. They also found a similar result. There is a reduction in the pre-diabetic conversion to diabetic conversion. So these are the three large trials that has been done, and they just not studied for this 2.8 year. They continued studied this trial even after 20 years, and they found that there is a sustained uh, beneficial role of lifestyle modification. This darkwing trial, they observed for 20 years, and they found it is still 47% reduction. In Finnish, they found they follow for 7 years. They found 47% reduction in the diabetes. And this diabetic prevention program, that is, then they followed it, that they called it as a diabetic prevention program outcome trial. They continued that trial. So after 10 years, they found 34% reduction in the diabetes incidence in the lifestyle group. And they followed further for another 5 years, means total 15 years. After 15 years, they found 25% reduction in this. So these are the lifestyle intervention. Is there any drug required for prevention of pre-diabetes? Let's see that thing, what the data says. So ideal pre-diabetes drugs should have this thing. They should address pathophysiological mechanism. Their weight loss should be there, and they are less toxic effect, and CV benefit should be there. So we have done Indian DPP trial also. That trial has been done, where the group is divided into control, lifestyle intervention, one with metformin and one with the combined lifestyle plus metformin. So they found similar reduction in the lifestyle, metformin and combined group around that. So compared to that USA DPP trial, the Indian diabetic prevention trial found that metformin was effective in low dose also. So in the USA trial, they have used 850 mg BD, that is total 1700. And in our trial, 500 of the dose was used for to reverse the pre-diabetes. And they found it is very effective. So that's what I said, 15-year follow-up of diabetic prevention program outcome study. So lifestyle intervention and metformin significantly reduced diabetic development over 15 years. These are overview of principal diabetic prevention trial with the evaluation of metformin. There are many trials they have done, and that supported the role of metformin in the prevention of prediabetes. This is the meta-analysis of our metformin to undo prediabetes, and that favors the metformin. Odd ratio, you can see it is reduced. So metformin was not the only drug they tried. There are many other drugs also tried. One is acarabose, one is pioglitazone, rosiglitazone, and they have tried weight losing therapy also, drugs like orlistat, topiramate, and bariatric surgery is also there. So this study has been done for this drugs also, and they found there is improvement in that also. Reduction in they found reduction in the risk of type 2 diabetes. So what ADA has recommended there? So US FDA, there is some little controversy happened few years back. US FDA has not approved any drug for prevention of prediabetes. But now ADA 2021 has latest recommendation. They have prescribed metformin for the prevention of type 2 diabetes. And it should be used in the particular group, one who has the BMI more than 35, those aged below 60, and women with prior history of gestational diabetes mellitus. And the fourth group is one who is trying with lifestyle modification but failed to achieve their reduction in HbA1c. Their HbA1c1 level is increasing despite of lifestyle intervention. This group can also be given metformin. So these are the commonly used anti-diabetic to undo prediabetes. That's what I told. These are the another trials they have shown. These are the drugs trials. They have done studies and they found there is a reduction in the prediabetes. But they have tried insulin also for prevention of prediabetes. This is the origin trial. And they found that there is a 31% reduction in the pre-diabetic group. So these drugs are tried, insulin means basal insulin, other drugs, but at present metformin was prescribed, means metformin was recommended by ADA. Though metformin was recommended in practice, only 1 to 4% are taking drugs for pre-diabetic. So this is a risk stratification treatment strategy for pre-diabetic. It is divided into 3 zones: low risk, medium risk, and high risk. In high risk, where above 6.2 HbA1c, metformin was tried. The counseling is very important. Follow-up counseling is also important once you diagnose with pre-diabetes. It shows important to success, and we can monitor weight loss progress, and we can give further continue lifestyle modification counseling can be given. Consider pharmacological therapy, metformin if appropriate. If you are pre-diabetic, when you check the diabetes status, if your pre-diabetes status is normal, if you are not pre-diabetic, if you are normal, then you should check after 3 years for screening method. And if you are pre-diabetic, then you should check annually, whether you are converted into diabetes or not. Because every year, 11% of pre-diabetic that converts into the diabetic zone. So it is possible to prevent diabetes with this all lifestyle intervention, regular physical activity, shedding some weight. So what is the take-home message we'll say? There are considerable comorbid conditions associated with pre-diabetes may often go unnoticed. This pre-diabetes is reversible, or at least you can delay the progression of diabetes. That is the most important take-home message. And it is significant importance to screen and identify those who are at risk. Lifestyle intervention is a cornerstone modality of the treatment. The priority should be given who is at high risk of developing type 2 diabetes. And there is a data, there are many trials are been done, and they have given robust support or data was favoring metformin, the efficacy and safety profile of metformin for diabetic prevention. So the thing is that you should first try with the lifestyle intervention. If you are not able to do it, or despite doing that, if you are failed to achieve your this reversal rate, you can try for metformin. Thank you.
Any questions? Nobody have any questions? Audience, anybody have? Any questions? Thank you, sir, for giving us a wonderful knowledge. How can we prevent diabetes, pre-diabetes? Okay, lifestyle modification is the first and primary thing, right? Next, we are going to see the diabetic foot care. For the same, I would like to invite Dr. Srikant Raju, sir, studied in MBBS and MS in general surgery, DNB in vascular surgery. Sir is working with as a senior consultant vascular and endovascular surgeon specialized in foot care. Over to you, sir, to present the diabetic foot care.
Good afternoon, everyone. I think post-lunch session, everyone will be in the hyperglycemic state. I think you might be very much sleepy. You might be listening the only word diabetes since morning. I know it's difficult for you guys, but so let us see how well I can entertain you guys and teach you something in this. Okay, okay. So I am going to speak much of like current trends in management of diabetes. Okay. So coming to the introduction, I think many people have spoken to you. It's estimated that every 30 seconds, a lower leg is lost because of diabetes somewhere in the world. And 70% of the amputations which occur in the world is because of diabetes. So foot problems are the commonest cause of admission to the hospital, and most of the people lose their uh, I mean, most of the people are bread earners in their family who are getting affected because of this diabetes. They will be developing the diabetic foot ulcers. So their economic status is also being deprived because of multiple admissions occurring to the hospital. So it causes an economic burden to the family. Okay. So this is a marvel of the foot. Why we call it like that? Because the most abused part in our body is our lower limbs, and probably all of us might not even care to see or give a glimpse at our legs while we bath. So an age-old patient who is having a diabetes, you can't expect them to see their foot for any new ulcers or blisters. So that is the most commonest thing usually happens, because by the time they realize that they have a ulcer in the foot, that will be an end stage where they might be losing toes, they might be losing forefeet, or sometimes they might be losing their below knee or a bony leg, and sometimes life also. So that's why a foot care is very much important. See, it is said that a person takes nearly 7,500 to 9,500 steps per day. He walks nearly 1,85,000 kilometers over his lifetime. It's something like 4 times around the world. You understand that much work is being done by our lower limbs. So that is the most neglected part, which does most of the work. Okay. So by 2000 25, it is estimated that world population, in the whole world population, 250 million will be diabetes, and most of them will be from the India. And our country is considered as a diabetic capital. You understand? So the goals of amputation, our goal is to avoid amputations, to save limb, to save life. So how can we achieve that? That is by patient education, comprehensive foot scanning, foot care, and self care. So most of them, 85% of the amputations which occur are preventable, because when you observe the foot ulcers at a starting stage, it is easy to treat, it is easy to make them heal well, and it is easy to save them. Okay. So this is a vicious cycle which usually causes, diabetic foot ulcers, because most of the people are neuropathic. They don't have sensations in the foot. So like when we walk, when we come across a small rock or small thorn, if it tricks us, because of pain, we observe where is it. But this patient doesn't have that sensation. So most of the time what it happens is they don't even realize that there was an injury, and by the time they realize that that injury has occurred, there will be an abscess formation leading to a large ulcer, and even bony infections also sometimes. So this neuropathy leads to infection. Infection leads to ischemia. Ischemia means when there is no blood supply, the wound healing will not be as good as a normal person who is having a good blood supply. So when these three things play together, that leads to the development of a diabetic ulcer. So already I spoke about neuropathy, so I don't want to get you bored with that. I think many people have spoken about these things. So whenever a patient comes to my clinic, my thing is to see where is the foot ulcer, what is the size of the ulcer, how many ulcers are there, what is the vascularity of the ulcer, and how severe is the infection part in that. So this becomes a risk assessment protocol for me. And coming to the pathogenesis, I think many people have spoken about this, so I'll skip this slide. So there are many foot classifications where, diabetic foot ulcers classification. In them, Wagner's is the most simplest because people can easily remember. But I don't want any one of you to remember that. Only thing is it helps in grading the wound from a superficial ulcer to a dead tissue and extensive gangrene. So it is categorized into 1, 2, 3, 4, and 5 grades. And Wi-Fi classification is one more classification. It's medically accepted. This classification, it takes all criteria of a diabetic wound. How is the wound? What is the status of its vascularity? And what is the status of its foot infection? How severe it is? According to that, the grading system is arranged, and it grades from 0 to 3. 3 means it is very severe. In such situation, patient losing toe and foot or leg is more, and there is high chances of amputation. So what are our therapeutic objectives in a diabetic foot? The most and prime important thing is the patient education. Patient should be educated how to take care of their own foot. That is the prime goal. Because whoever the patient is there, if they get an ulcer, our patient education should be in such a way that they how to heal that wound, and what are the precautions they have to take to heal that wound. That would be the primary thing. And secondary thing is they should never get one more ulcer in their life. So how should they maintain that? And if a patient is with diabetes is presented to us who has no ulcer, our patient education should be in such a way that they never get an ulcer in their life. So these two things, when we concentrate, so we can decrease the disease burden. And one more important thing in that therapeutic objective is establishing a good arterial blood supply. As a foot care specialist and as a vascular surgeon, we see most of the patients in such a way that not only their infection part is controlled, but also their blood supply is re-established so that they have a faster rate of healing. And management, I think many people have spoken about that, so I'll skip this slide. So the most important thing is in an X-ray, what we see osteomyelitis, whether there is a bony infection or that. While that arrow you are seeing, that is showing the osteomyelitic tip of that bone. Okay. And the same thing in MRI we are seeing, and the same thing we are seeing technician scan. Out of these three things, MRI has a highest sensitivity in detecting the bony infection, sensitivity and specificity in detecting the bony infection. But for each and every patient, we can't afford to have an MRI. So the most common investigation we go is X-ray. It helps in most of the times in predicting what is the status of the foot. So in a foot examination, as a vascular surgeon, what we do is we examine the foot. What is the deformity? How many ulcers are there? What are the type of toes, hammer toes, or how is the arch of the foot? Is there any charcot foot? What is the texture and integrity of the skin, texture of the nails, and loss of hair? These things we observe. According to these things, we can grade that what is the severity of the disease which they are affected. So I am showing few photographs so that I'll draw your attention towards the slides. So here we are seeing that patient is having an intrinsic muscle defect. So there is a muscle wasting in the foot, because of which because of peripheral neuropathy and those stuff, he has developed an high arch with hammered digits. Hammered digits is nothing like, it's like a hammer. If you can see that metatarsal bones are in such a way that it is projected downwards. Okay. And this is one more photograph which is showing a classical charcot foot. Like when we have an arches of foot, there will be a curvature at the foot. But here in this photograph, you are seeing that a flat foot. That is called rocker bottom foot. Okay. This is one more variation. A patient is having a prominent metatarsal heads, and the other patient, you can see that pitting edema is there on the foot. So as a vascular surgeon and a foot care specialist, we see to predict the severity of neuropathy and assess the degree of their sensation by standardizing two methods. One is the vibration sensation, that is called biostachiometer. And second thing is we use Siemens Meanstains 10-gram monofilament to assess the sensation of touch. So I'll show you the photographs how we do. That biostachiometer is used for vibration sensation. How is the vibration sensation they are perceiving? And that monofilament was used for perceiving the touch sensation in case of a diabetic foot patients. And these are the different sites at which we usually see to perceive their sensations. And in a foot care patients, what we clinically see is whether there are any palpable pulses or not, there or not. If the palpable pulses are not there, we examine for ABI, ankle brachial index, toe brachial index, toe systolic pressure, and transcutaneous oxygen tension, and ulcer examination we commonly do. So that ABI, ankle systolic pressure, and TCPO2, all these things when their normal values in grade 1, 2, 3, 4 as being depicted in this chart. So my aim is not to make you guys to learn all those values. My aim is to tell you that when a grade 3 patient with an ABI of less than 0.4, with an ankle systolic pressure of less than 50, with an TCPO2 less than 30 mmHg, it means that patient is having a severe grade of ischemia. So such a ulcers will not heal unless you correct their vascularity. Because most of you might have been seeing in your friends, relatives, or in their homes, few patients who are having a diabetes, they'll be losing multiple toes. That wound is not healing n number of times if they do debridement or if they take a proper wound care also. Why? Because that vascularity part, most of the people will be missing. If you doesn't miss that vascularity part, then that wound will heal at a faster rate. Okay. So this is a handheld Doppler, which we use commonly in our vascular clinic. And most of the times, some of you might have seen me using even the Watt side also. And these are the most advanced techniques like digital camera imaging. What this does is this captures a photograph of the wound, and on serial examination, on serial visits, when the patient comes to us, how much decrease in size of ulcer is being depicted by this help of this camera, which is not available in India. Probably it is available in foreign countries. In future, probably it might be available with us also, but let's see. So one more technique is near infrared optical scanner. So I'm not going to read all these things. Why? Because again, you guys will get bored, and I think a few people are yarning already. So I don't want that to happen. So I'll show you the photographic way in which probably you might be interested in seeing it. So what it does is near infrared rays are directly depicted onto the ulcer. There will be a reflection of this infrared rays. These reflected infrared rays are being captured, and those things are being seen in on the ulcer way. For example, there is a non-healing ulcer, and there is a healing ulcer. A is non-healing ulcer, B is healing ulcer. In the healing area, that reflection part will be increased. So with that, we will be knowing that this part is healing and this part is not healing. Okay. This is also not available in India, so don't worry. I think no one will ask you. So let's see, in future we might get. So treatment strategy. So what we do is infection to treat neuropathy and pressure ulcers. Third one is ischemia, and a mixture of all these things, because we can't say that each and every patients with all these things. You understand? So infection part, when infection is there, we try to save limb and even life. Okay. And we simple things like incision and drainage of abscess also might save a patient if you do it at right time, and appropriate antibiotics, and probably regular surgical debridement on the OPD basis also. And as I already said, vascular assessment and revascularization is important in any wound healing. Okay. So antibiotics we have to give for all patients. So I don't want to bore you guys with this. So I'm skipping this. So coming to the surgical part. So what commonly we know is elective way, doing it precautionarily before something happens. That is like if there is a deformity in the foot, we do a deformity reduction, exhaustectomy, reconstructive surgeries. These are called elective surgeries. Reactive surgeries, most of you people might be doing, most of our surgeons will be doing those things, and those patients will be coming to you in the ward side. They are like incision drainage, debridement, amputations. These are definitive things. It is done everywhere in the world. So, and one more thing is definitive, that is done by only vascular surgeons like us, who do an angioplasty, stenting, or a bypass to heal the wounds. And then comes the plastic surgical part like skin grafts or flaps, which we might be using. And these debridements are also, there are types: enzymatic debridation and mechanical surgical. Enzymatic, you most of you people might be knowing, we'll be using that papaverin, the debridase ointment. Most of the times it helps in liquefying the necrotic part, and autocatalytic property in which it helps in debriding the wound. So that you guys, most of you people will be knowing in this. And mechanical, these things are also not available with us right now, but in future we might have it. That is high pressure water jets and ultrasonic devices. I'll show you a few glimpses of that. And surgical debridement, that is gold standard. Everyone knows, everyone will be doing. So this is an ultrasonic debridement. How we do is, we take an ultrasonic device, we spread those ultrasonic waves, they create a mechanical energy. When they go into a sloughy and infected fluid area, they create a molecular oscillation. This molecular oscillation leads to the development of water bubbles. After developing these water bubbles, what it occurs is these water bubbles explode with some energy. So that energy is sufficient for a devitalized tissue to get destructed and removed automatically. Okay. And you might have a doubt, sir, if normal tissue is also there, no, will that be destroyed or not? That will not be destroyed, because it has a membrane. Every cell has its own strong membrane which protects it from the ultrasonic waves. So only devitalized tissue only will be debrided by this technique. So this is the machine. So to clinch your interest in that, I just portrayed those slides. Coming to low level laser therapy. In this low level laser therapy, what we do is with that probe, which is being seen in that photograph, we try to massage over the wound area. So what it causes increase in microcirculation and macrophages activation it does. When these things does, there is an anti-inflammatory activity and analgesic activity, which leads to regenerative, bacteriostatic, and bactericidal clinical effects. So these all things combined together, it helps in wound healing. So simple thing is, when we use a low level laser therapy, it helps in wound healing. That is a bottom line point. So this is BRH-A2 device. This is also something like that. There is a probe like ultrasound probe which the operator is using. They use over the ulcers, which causes massage. This ultrasonographically used massage will generate an electrostimulation, which helps in increasing the vascularity, which further helps in healing the wound. Natrox oxygen therapy. In this Natrox oxygen therapy, the machine, the device which is attached to that ulcer area, what it does is it captures environmental oxygen and it delivers to the wound area. So when there is a high oxygen delivered to the wound, it helps in wound healing. That is a simple principle. And when ulcer doesn't heal more than 4 weeks with the standard therapies, in that situation, we will be giving a adjuvant therapy. These adjuvant therapies are like derma paste. In this derma paste, what we do is that probe-like thing which is put on the ulcer. I think you guys can see that shock waves are applied to that ulcer. This helps in increasing the angiogenesis, perfusion arteriogenesis, helps in formation of a biofilm, inflammatory modulation, increasing cellular growth factors, leading to angiogenesis, granulation, and epithelialization. So this is a proper channel in which a wound healing occurs. Coming to the amniotic membrane. Amniotic membrane is made up of amnion and chorion. So amniotic membrane has all growth properties. Like it has all extracellular matrix proteins, growth factors, and collagen factors. These all things combined together help in wound healing. So living cellular therapy, there are two types. One is appligraft and dermagraft. In the appligraft, they use a neonatal foreskin, which is cultured to form a bilayered skin substitute. So there are studies in which it is shown that people who have used appligraft has a little bit faster healing rate. When it comes to dermagraft, it is this dermagraft also produces a good healing rate that is being depicted in most of the studies. And allodrum, it is nothing but freeze-dried human dermis. It provides a collagen scaffold for the ingrowth of granulation tissue. So in a nutshell, if I have to say, all types of these artificial things are used for faster healing rates. That is the bottom line, which everyone has to remember. So there are ointments like growth factor devised ointments like pellet-derived growth factor, epidermal growth factor. They come in different brands. They also applied locally so that it helps in faster healing rate. Stem cell therapy. And this stem cell therapy, multipotent stem cells, which are harvested from adipose tissue, bone marrow, umbilical cord, they are used for provocating and improving the cellular level angiogenesis, which helps in faster healing rate of the wound. There are different studies which are being done. Still, it is under study, but in future, where you are not able to heal by surgical process, in such patients, you might be using this stem cells. These stem cells are usually injected in the muscle directly, or they can be injected intra-arterially, or sometimes in the wound surrounding areas also, these stem cells can be injected. So negative pressure wound care therapy. This is nothing but VAC therapy. Most of you guys might have seen in the clinical practice. This VAC therapy with an instillation option is a little bit more advancement. This installation process will help in installing the fluid. It might be an antibiotic, it might be a normal saline, or it might be something like a silver solution, which helps in wound healing. So when this continuously froze and cleans the wound, that helps in faster increase in microcirculation and faster healing rate. This hyperbaric oxygen. Hyperbaric oxygen, that figure what you are seeing is a glass chamber. In this glass chamber, patients are subjected to a high oxygen therapy, 100% oxygen therapy. When a wound is provided with 100% oxygen therapy, those wounds heal really well. I think you guys might have heard that Michael Jackson, he has used an oxygen chamber so that his body doesn't age and he can live for long years. He thought in that way. That same, this principle comes from that. And coming to the wound care products, the primary goal is to keep the wound moist, which helps in wound healing. And second thing is wound dressings. There are different type of wound dressings. So hydrogels, alginates, collagen, silver dressings. These are different things. All these things are used to help a faster healing rate for the wound. So these are many names are there. I don't want you to remember anything. These are human skin substitutes. So these products are commercially available. So when the patient doesn't have his own skin substitute also, in that situation, we can be using these things. Antibiotic beaded dressings. These are special innovative. So they are easily mixed with liquid, powder, heat sensitive antibiotics, and predictable elution profile, absorbed at a optimal rate, which helps in proper wound healing. So that antibiotic beads are being applied to such a wound, so it lead to a healing of that wound with a good granulation tissue. EDX 100 wound care system. It's nothing but it delivers the nitric oxide to the wound area from the environment, which helps in faster healing rate. So this is not yet approved. It's still in the approval state. There are few studies done outside which shows that EDX 100 wound care system is helpful in faster healing rate. So this is a surgically debrided wounds. You can see the classical picture of an abscess following a large wound, which has healed completely with a scar. So the same thing, the callus thing has been removed surgically. So different minor amputations like Chopard, Lisfranc, transtarsal amputation, transmetatarsal amputation has been shown in these pictures. So majority of Indians are, as I said already, they are single bread earners. So if they lose their leg, they lose their economy and their family will be at a soup. So most of the times we try to save most of the limbs, but following amputations, most of the people will be feeling that they are physically handicapped and they are deprived. They will be in a depression. So successful rehabilitation is only established in 36 to 76% of the people only. Rest of the people, they will be bedridden. So this thing should come off, and patients should be made aware that even though they lose their limbs, they can have a successful, happy life with an artificial prosthesis. Okay. And it is known that if a single AK amputation surviving more than 2 years, the risk of losing contralateral limb is 50%. If a person loses a belonie or a bony amputation, in next 2 years, there is a 50% risk of losing the other leg also. So to heal the wounds, what as a foot care specialist we suggest is offloading footwear. There are different types of offloading footwear which are available. It is customized plate insoles we will be using, modulated thermoplastics, felt foam technique we will be using. Once the ulcer heals, foot screening we will do, moduled ankle foot process, and customized molded shoes will be used. So these are the few photographs. That is total contact cast, and this is Scottish boot, ankle foot orthosis, and these are different footwears like how we can use for a diabetic foot patients. So this is a back therapy photograph. This is a normal back therapy. I think you guys most of them might be seeing this one. As I said, patient education is the most important in healing these wounds. So whenever a patient comes to us, how we have to advise them? See, in a simple language, if I have to say, any patient with diabetes comes to us, we have to tell them that every day morning when they woke up from bed, like what we see our face in the mirror, we should ask them to take a mirror and ask them to see, are there any new ulcers, new bruises, new cuts in the plantar surface? Because if you observe it early, you will be easily treated. What happens is, see, we ourselves don't bend and see our plantar surface by ourselves. A patient who is above 50 years with comorbidities like diabetes, hypertension, and heart-related issues, with osteoarthritis of knee, most of the people will not be willing to bend or not be able to bend and see their own foot. So this mirror will help them at least to partially see what is happening to their foot. Okay. And apart from that, we should ask them to moisturize their foot, because there is a loss of sweat glands because of loss of hair and those stuff in their foot. And they have to wear socks, and they have to prevent wetness between their interdigital spaces. So these are the simple precautions which if they take, I think our services might not be useful. I mean, they are necessary to them. Okay. So next slide, how we increase the blood supply. That is a bypass what I did for a patient. distal, I mean that CFA to PTA bypass, that graft you are able to see there, that vein graft. And this is one more patient who had underwent an artificial graft outside somewhere in Chennai. And following that, he developed gangrene of his second and third toes. So they amputated outside, and that wound was not healing in the first photograph. Following that, I did femoral artery to below-knee popliteal artery bypass. So that bypass graft, that vein graft, you are able to see. Following that, patient has to undergo a TMT amputation. Following that, I applied a skin graft to that forefoot. That patient, that ulcer has healed well. So as a open and endovascular surgeon, we try to see which patient will suit for open procedures and which patients will suit for endovascular procedures. See, endovascular procedures we suggest to the patients who are elderly age group with comorbidities like heart issues and stroke and hypertension. In such patients, anesthesia is a risk factor. And in such situations, minimal hospitalization and will be, I mean, they will be benefited by this endovascular procedures. So some simple SFA popliteal angioplasty pictures I am showing here. And this is iliac artery angioplasty. That iliac occlusion is there. Following angioplasty, you will be able to see that good blood supply and that wound before and after that angioplasty. These are few more patients. So at the end, this is the result. So we ourselves are going to establish an advanced diabetic foot care unit. So with all foot care facilities, so that our intention is to serve all the diabetic foot patients before they develop ulcer only, to prevent the development of ulcer. If the patient has already an ulcer, to make those ulcers heal well. So there is a famous saying by Bernard Shaw. I marvel that society would pay a surgeon a large sum of money to remove a person's leg, but nothing to save it. That is a truth. When we suggest for revascularization, they will not pay money much. The economic constraints come into the play. But if the patients, they have to remove their toes, forefoot, below-knee or above-knee. So why am I saying this one is, most of the patients, when they come from peripheries towards us, they will go through a multiple doctors and multiple hospitals where they will be economically ruined before knowing what is the proper treatment. Because 50% of the patients with diabetic foot ulcers are destined to have a decreased blood supply. If you don't establish the blood supply, those wounds are not going to heal whatsoever you do. Thank you.
Any questions from the audience? Nobody has any question? Give her a mic. Please ask in the mic.
Which was the dressing were suggested for the pressure ulcers?
See, normally pressure ulcers usually occur at a point where you have a pressurous points. So in such cases, what we do is we use an offloading footwear along with normal dressings. See, normal dressing like saline dressing we can do. Apart from that, we use a silver coated dressing, Aquacel AG, and a few more latest dressing materials have been come. We can use all those things. But instead of using those things, you have to have an offloading footwear. Offloading footwears are nothing but in the insoles, wherever the ulcer is there is a cavity is being created, so that in that ulcer area, in that insole, if the ulcer sits, there will be a faster healing rate because there will be no pressure from the footwear in that area. So the main aim of offloading footwears is to heal the pressure ulcers. Okay. Anyone else have any queries? You can ask me.
What is the schedule for that dressings are even daily or
See, it depends upon the wound. How is the slough? Is there any infection? Mostly it might be a daily dressings. Sometimes it might be alternate dressing. If you are using specialized dressing, few specialized dressing like those people will be asking us to, when there is a clean wound, you can do a dressing after 5 to 7 days also. So it depends upon the dressing what you are using. It is depends upon the status of the wound also. Okay.
Thank you. From that point of view, ward nurses, ward in charges, ward nurses, CCU nurses, do you have any other questions? Anita? Backbenchers. Vimla and team, Sandhya, here you have seen many cases, right? Both the Sandhyas. Sunita. So I have one question. Srikanth sir. So, especially diabetic foot, okay. Will you recommend any special footwear or, this, especially necrotizing patient, the grade 4 diabetic foot also? When we see certain patients with vac therapy, how it helps vac therapy? It's a long-term dressing required at home care, or why don't you suggest some kind of, methodology where we can, take care of proper wound healing? What kind of, current practices where we are using? Being a podiatrician, you have seen many cases. What kind of research evident with vac therapy will help us, or, any kind of clinical evidence-based practices where nursing interventions are required at home care for public awareness. Can you give some tips for our nurses?
See, there are two questions you have asked. First one
sir.
is about back therapy. Second one is footwear.
Yes,
Are
sir.
you suggesting? See, back therapy usually helps in creating a negative pressure in the wound area, which helps in faster development of granulation tissue. So when there is a big cavities or big wound areas, in order to heal it well, back therapy will be useful. But vac therapy can't be used everywhere. It can be used only on the clean wounds. So before vac therapy also, most of the wounds require surgical debridement, which is commonly done everywhere in the world. You understand? Once we think that that wound is properly clean, there is no remnant of infection in that. In such situations, we will be advising if there is a larger wound area, in order to heal it fast, we might be asking them to undergo the vac therapy. So the important thing is the negative effect of vac therapy is little bit more costlier for a normal common people like an Indian population. But one more thing, in a good way, if you have to see, that dressing is usually done every fifth day. So 5 days, there is no need of any dressing for the patient. So in a way, the patient will be comfortable. Otherwise, every day or every alternate day, most of the patient has to go to a hospital setup for getting their dressing done in a proper way. And most of the times, what happens is when the patients come for the periphery, they go into RMP based practices where they don't follow all the sterilized precautions like what we do. In such situations, these wounds will be further deteriorated. So back therapy will be helpful in that way. And coming to the footwear, so most of the patients who are having diabetic, like I already said in my lecture, that a proper footwear is mandatory for all the diabetic patients. Why? Because if a patient has having diabetes for 5 years, they obviously develop a neuropathy, and they have a bony deformities like all many photographs have shown. So as the duration progresses, their foot obviously takes major changes. So they can't have a footwear like a normal person because that will not suit their surface. You understand? In such patients, what we do is we customize a footwear with a proper insole, which will be fitting their own problem, customized problem. So we will do a foot scan. According to this foot scan, where are the pressure areas which has to be protected? What are the ulcer locations where you have to offload? Those things we will be focusing so that it helps in occurrence of wound, first thing, and it secondly, if there is a wound also, it helps in faster healing rate. Most of the patients who are having plantar fasciitis, they will be having a lot of pain because of the infection in the foot because of facial involvement. In such patients, when you use that proper footwear for their foot, these things can be avoided. Okay, thank you.
Any other questions? Thank you so much, sir, for giving us a lot of knowledge regarding the care and treatment of diabetic food. What are the methods you will see to prevent a diabetic foot? No answers? Tell. What are the methods are told to see? No, the normal care which we need to practice daily. No, how to prevent this? We have to check the food because this is the most negligent part of our body. So that we have to see which part you will see. The soul always. So any other questions from the ICU nurses? Which you sitting at the back. You have one question? So if anybody has a, online who are seeing, you can always ask the questions. You can post the questions and our experts will be answering you.
Any further questions from anything? Offline people from YouTube viewers, Zoom link, people can chat your questions in chat
From the
box.
other branches, you can post your questions. Now, let us see the topic of gestational diabetes. For the same, I'd like to call Dr. M.N. Lakshmikant Reddy, sir. Sir is a consultant physician and has vast experience in this field. Sir completed MBBS and MD in General Medicine from Government Medical College, Anantapur. Sir is one of the proud members of Indian Medical Association. Sir is with us as a consultant general physician in Medicover Hospitals. I'd like to invite you, sir, for the topic of gestational diabetes.
Good afternoon, everybody. Thanks for the introduction, madam. Yeah. Today, generally as gestational diabetes is what we call it as diabetes in pregnant ladies. So overall, I'll just discuss about diabetes and pregnancy, both diabetes, which is happens after during pregnancy, and diabetic people who become pregnant. Okay. So diabetes in pregnancy is two categories: pre-gestational diabetes and gestational diabetes. As I told you, pregnancy in pre-existing diabetes. So already diabetic patients who become pregnant. That is it's as usual, they are normal diabetic people who get pregnant. So there are two types, type 1 and type 2. And the other is diabetes diagnosed in pregnancy. So what is that is called gestational diabetes. So diabetes in pregnancy, what are the phases which we should consider? One is like in pre-gestational diabetes, we should think about pre-conception counseling, management during pregnancy, management in labor, and postpartum considerations. The same thing with gestational diabetes is like first we have to try to prevent it, screen, diagnose, and rest all the three things will be the same, because there will be a lot of difference pre and post partum, what has to be done in these two categories. So now first, in dysglycemia in pregnancy can result in adverse pregnancy outcome. So elevated glucose levels can have adverse effect on the fetus. So in first trimester, there can be fetal malformation. So you have to be as the sugar should be very well controlled in first trimester, because that is the time where the um, worst outcomes can be there. And second and third trimesters, the risk of macrosomia and metabolic complications can happen. So if you just see, this is a slide which will tell you the risk of any anomaly forming with the horizontal one is the HbA1c and the absolute risk. So the more the HbA1c, the risk, the risk of fetal anomalies. So preconception counseling for pre-gestational diabetes. Advise reproductive age women with diabetes about reliable birth control. So metformin in PCOD or PCOS may improve fertility and need to warn about possible pregnancy. Metformin is safe for ovulation induction in PCOD. Achieving a healthy weight is essential. Obesity associated with adverse pregnancy outcomes. So screen for any complications in pre-pregnancy and intrapartum, like retinopathy and nephropathy. Nephropathy should be assessed with assessed creatine, urine albumin creatine ratio. Women with albuminuria or overt nephropathy are at high risk for developing hypertension and preeclampsia. So it helps in both. So to reduce the chances of hypertension and preeclampsia also, this screening is important. So, what are the checklists for women with pre-existing diabetes? Use reliable birth control until adequate glycemic control is achieved. So, try to get HbA1c below 7, and if not 6.5 is even more safer. So, patients who are already on treatment and who get pregnant, metformin and glyburide, these are the drugs which can be used in pregnancy also, oral. And otherwise, they can be switched to insulin. So, assess for and manage any diabetic complications. And folic acid 1 milligram per day for 3 months pre-conception to 12 weeks post-conception is indicated. And discontinue any potential embryopathic meds. So some people who are diabetics can have hypertension and they will be on ACE inhibitors and ARBs. So you have to stop them. And next, normally there are some, it's good to know like what care should be taken before you get pregnant. All women of reproductive age with type 1 or type 2 diabetes should receive ongoing counseling on reliable birth control, the importance of glycemic control, and the impact of BMI, and the need for folic acid, and stop the potential embryopathic drugs which I have told. And women with diabetes, type 2 diabetes with regular menses or PCOD who lose significant weight or are started on metformin should be advised that fertility may improve and be counseled regarding possible pregnancy and receive preconception counseling. And preconception care, again, before attempting to become pregnant, women with type 1 or type 2 diabetes should receive counseling that includes optimal diabetes management, including nutrition, preferably in consultation with a professional pregnancy team to optimize maternal and neonatal outcomes. So the main targets what they have to achieve is HbA1c less than 7. If not, 6.5 is also good. It always decreases chances of risk of having a spontaneous abortion, congenital anomalies, preeclampsia, and progression of retinopathy in pregnancy, and the chances of stillbirth. So folic acid is to be, as discussed, it should be at least 3 months pre-conception and should be continued 12 weeks of gestation to prevent congenital anomalies. And ACE, ARBs, and statins, these drugs should be discontinued. So women on metformin and or glyburide, these are the only two drugs, oral drugs, which are indicated in pregnancy, which can be taken. If the sugars are not controlled with these drugs, they might be switched to the insulin. So assessment and management of complications. So they should be undergoing ophthalmologic evaluation for vision care and the pregnant before planning pregnancy. And first trimester as needed during pregnancy. After that, and again within the first year of postpartum, in order to identify progression of retinopathy. Most frequent retinal surveillance during pregnancy, as determined by vision care specialist, should be performed for women with more severe pre-existing retinopathy and poor glycemic control, especially those with greatest anticipatory reductions in HbA1c during pregnancy, in order to reduce progression of retinopathy. So women with albuminuria or CKD should be followed closely for the development of any hypertension and preeclampsia. So next, management during pregnancy. Normally, type 1, there will be two types, type 1 and type 2. Type 1 is basal bolus insulin therapy. 3 to 4 injections should be given per day and can be advised continuous subcutaneous infusion. Normally, basal bolus is like one long acting basal insulin and three short acting bolus before breakfast, before lunch, and before dinner. And type 2 switch to insulin and individualized insulin therapy with close monitoring. As I told you, bolus insulin aspart or lispro is better than regular because they are very short acting. And basal insulins or long acting is like Detimer or Glargine, which is Lantus or Tresiba, what we see regularly. See, pregnancy management for pre-existing diabetes. See, normally for any other diabetic patient and compared to pregnant women who have diabetes, the the guidelines or the values of blood glucose, target blood glucose levels are different. They have to have fasting blood glucose less than 95, and 1 hour postprandial should be less than 140, and 2 hours postprandial should be less than 120. In normal people, anything above 125 only we say it is fasting sugar. Anything above 125 we say as diabetes. But pregnant ladies, fasting should be less than 95, and postprandial 2 hours should be less than 120. Post breakfast, post lunch, post dinner, anything should be less than 120. And HbA1c should be 6.5, and less than 6.1 is even more better because it has lower rate of stillbirth and infant death. Individualized targets in those people with severe hypoglycemia and awareness. The more the hypoglycemic events, uh, you might have to change the targets. And uh, type 1, as I told you, continuous glucose monitoring should be in type 1 because they have high chance of going into hypoglycemias, type 1. So continuous glucose monitoring should be there. Encourage weight gain according to Institute of Medicine recommends to stay, have more, encourage weight gain in type 1 people. And aspirin, ASA, salicylic acid, aspirin is advised to reduce the risk of preeclampsia starting at 12 to 16 weeks of gestational age. So pregnancy management for pre-existing diabetes. So retinopathy surveillance once, one visit in first trimester, which is after as needed, and more often with more severe retinopathy, large drop in HbA1c, and poor glycemic control. Nephropathy, good BP control is essential, and watch for hypertension and preeclampsia. And pregnancy management of same this thing, fetal surveillance is needed, should be started at 30 to 32 weeks of gestational age, then weekly from 34 to 36 weeks until delivery. Earlier onset and are more frequent, those at highest risk. Uncomplicated pregnancy induce 38 to 39 weeks of gestational age to decrease the stillbirth. Induction prior to 38 weeks for other fetal or maternal indications. So because they have to wait at least for 38 to 39 weeks because the lung maturity will be slow in diabetic women, pregnant lady. So once pregnant, women with type 2 diabetes should be switched to insulin, non-insulin antihypertensive agent should be only discontinued once insulin is started. So pregnant women and pre-existing management mainly receive individualized basal bolus regimes. Your target should be fasting less than 95, 1 hour postprandial less than 140, 2 hours less than 120, and aim for an HbA1c of less than 6.5. Less than 6.1 is even better. So be prepared to raise blood glucose and HbA1c targets in presence of severe hypoglycemia during pregnancy. And serum blood glucose level should be both preprandial, postprandial to improve pregnancy outcome. So the healthcare provider should discuss appropriate weight gain at the initial visit with regular throughout pregnancy. Recommendations for weight gain during pregnancy should be individualized based on the Institute of Medicine guidelines. So management in pregnancy, as I told you, these are short-acting, ultra-short-acting aspart, lispron, glucilin are may be used with pre-existing diabetes to improve postprandial blood glucose and reduce the risk of severe maternal hypoglycemia. So short actings or ultra short actings are better tolerated by the pregnant women. And Detimir or Glargine, these are long acting, which are better than NPH and all, like Mixtard or premix insulins. So women with pre-existing diabetes should start as aspirin, 81 mg at least daily at 12 to 16 weeks gestation to reduce the risk of preeclampsia. And women with type 1 and insulin treated type 2 diabetes who receive antenatal corticosteroids to improve fetal lung maturity should follow a protocol. See, this has to be closely monitored because all the pregnant women who have diabetes, most of the people would be advised steroids during the antenatal. So, as most of the people would be knowing, steroids will increase the blood glucose levels. So, whenever you are administering steroids as a pregnant ladies, you should closely monitor depending upon how bad his patient sugars are there. So, you have to be more careful. And with type 1 diabetes, pregnancy should offer use CGM is continuous glucose monitoring. It's better to use that to prevent neonatal complications and for the tight control of glucose also. So in women with pre-existing diabetes, assessment of fetal well-being should be performed at 30 to 30 as it was discussed. So as I discussed, most of the diabetes induction is advised at 38 to 39 weeks of gestation to reduce the risk of stillbirth. Induction prior to 38 weeks is only indicated if there are other exists such as poor glycemic control, potential benefit of early term induction needs to be weighed against the potential for increased neonatal complications. So management during labor, try closely monitor the sugar, try to keep the sugar levels between 72 to 126. See, these are just numbers, but ideally you have to keep between 70 to 125. That is how we have to try to keep it. Okay. And most of the intrapartum also during pregnancy, women should be closely monitored during labor and delivery, and maternal glucose levels should be kept between 72 to 26. These are guidelines, but this will try to prevent complications. And glucose monitoring, all these things, insulin pumps can be used depending upon how bad the sugars are. Continuous infusion should be given or not. And postpartum comprehenses adjust the insulin to reduce the risk of hypoglycemia, encourage women to have breastfeeding, reduce neonatal hypoglycemia and offspring obesity. So metformin and glyburide can be used during breastfeeding. No long-term data, but appears to be safe. So screen for postpartum thyroiditis in type 1 diabetes. Check TSH at 2 to 3 months postpartum. So insulin doses should be decreased immediately after delivery. So just at post delivery, almost most of the sugars, blood sugars will come down to prior to what they were before the pregnancy. So there will be a drastic drop in the requirement of the insulin. So there should be decreased immediately after delivery. And women with pre-existing diabetes should have frequent glucose monitoring in the first days of postpartum as they have high risk of hypoglycemia. And postpartum, early neonatal feeding is indicated, should be encouraged immediately postpartum to reduce neonatal hypoglycemia. Breastfeeding should be encouraged for a minimum of 4 months to reduce offspring obesity and later risk of developing diabetes. Women with pre-existing diabetes should receive assistance and counseling and the benefits of breastfeeding. Okay? And women with type 1 should be screened for postpartum thyroiditis. Metformin glyburide can be used and which are safer even postpartum. So now the first part is pre-gestational diabetes, and now we'll talk about gestational diabetes. See, in women at higher risk of developing gestational diabetes based on pre-existing risk factors, nutritional counseling should be provided, healthy habits of healthy eating and prevention of excess weight gain to reduce the risk of gestational diabetes. Gestational diabetes screening, universal screening all over the world, they say screen for gestational diabetes at 24 to 28 weeks of gestational age. Screen earlier if risk factors for GDM are seen. Women at high risk for type 2 diabetes. Screen with HbA1c or fasting glucose if A1c is unreliable in first trimester. And HbA1c more than 6.5 or fasting glucose more than 126, treat like not gestational diabetes, treat like type 2 diabetes. So if any HbA1c is more than 6.5 and fasting glucose more than 126, they should be treated like type 2 diabetes, but not like gestational. And confirm the diagnosis after postpartum. You have to ask the second group of people to check the HbA1c after delivery, whether they are type 2 diabetic patients who became pregnant or gestational diabetic. So why diagnosis and treat GDM? So these are the complications of what can happen with high blood glucose. Macrosomia is babies with large heads, shoulder dystonia, and nerve injuries can happen. Neonatal hypoglycemia, preterm delivery, hyperbilirubinemia, and chances of patients going to cesarean section, offspring obesity, and offspring diabetes is common. They are the complications which will happen with GDM. With this slide. So diagnosis of gestational diabetes. See, there are no clear threshold glucose levels above which the risk of adverse neonatal or maternal outcome increases. So this is a slide. How we can select an these are odds ratio. So these slides, these are all over the world guidelines. There are two ways how you this thing diagnose. One is preferred approach, one is alternate approach. I'll explain you in the next slide. See, in women with high risk of GDM, based on pre-existing risk factors, nutritional counseling should be provided in healthy eating and prevention of excessive gestational weight gain in early pregnancy, ideally before 15 weeks of gestation, to reduce the risk of GDM. So women at high risk for glucose should be so they should be counseled for nutritional counseling, excess gestational weight gain in early pregnancy, ideally before 15 weeks only. And all pregnant women not known to have pre-existing diabetes should be screened for GDM at 24 to 28 weeks of gestation. So there are preferred approach for the screening and diagnosis of GDM at 24 to 28 weeks is following. Screening for should be conducted using 50 grams of glucose challenges administered in a non-fasting state. It doesn't matter whether the pregnant lady is fasting or non-fasting, with plasma glucose measured 1 hour later. If a plasma glucose more than 140 after 1 hour is a positive screening test and is in indication to proceed for 75 grams oral glucose tolerance test. So first we'll give 50 grams of glucose tolerance test. If after 1 hour, if the glucose level is more than 150, we'll go for the oral OGGT. So OGTT is 75 grams of sugars, and we have to check plasma glucose more than 200 is diagnostic of gestational diabetes and does not see. I mean to say, in the glucose challenges, if plasma glucose is more than 200, you need not go for oral glucose test. So you can directly diagnose the lady with gestational diabetes. If GCT screen is positive, 75 gram glass oral glucose tolerance test should be performed as a diagnostic test. And if GDM is using one of the following, if one of the following is high, then you should consider them as diabetic. Fasting glucose more than 95, 1 hour plasma glucose more than 190, 2 hours more than 162. So there is an alternative approach. Forget about glucose challenges. Do directly 75 grams this thing. If fasting glucose is more than 92, it should be diagnosed as GDM. 1 hour more than 180, 2 hours more than 155. In India, more of we follow this test, second test. So most of the people will follow these things. So fasting more than 92, 1 hour more than 180, 2 hours more than 155. So women identified as being a high risk for type 2 should be offered earlier screening, like obesity, overweight mothers should be advised earlier screening on it, rather than don't wait for 24 to 28 weeks. Do it in first antenatal visit only to identify diabetes, which may be pre-existing. For those women with hemoglobinopathy or renal disease, the HbA1c test may not be the reliable and screening should be performed with plasma glucose. If HbA1c is more than 6.5 or plasma glucose is more than 126, the woman should be considered of having diabetes in pregnancy. And the same management recommended for pre-existing diabetes. So whenever you check any pregnant lady with HbA1c 6.5 and fasting glucose 126, you should treat them as a diabetic rather than gestational diabetes. If the initial screening is performed before 24 weeks of gestation and is negative, and the woman should be rescreened as outlined in recommendation 27 between 24 to 28 weeks. 24 to 28 week gestation, you have to do prior, you have done it or not. This is the time where you have to screen for gestational diabetes. And management during pregnancy. So receive nutrition counseling by registered dietitian to achieve their nutrition. Weight and blood glucose goals. Eat healthy diet, replace high glycemic index foods with low glycemic index foods to reduce need for insulin initiation and decreased birth weight. Discuss appropriate weight gain and healthy lifestyle interventions throughout pregnancy. Recommend weight gain according to IOM recommendations based on pre-pregnancy BMI interventions to reduce large for gestational age and C-section. Okay. So mainly gestational diabetes, the role of nutrition and lifestyle modification plays a major role. So this is instead of medicine guidelines, gestational weight gain, what they advise in pounds and kgs and all. If the BMI is less, recommended rate weight gain is 12 to 18 kilos. If BMI is between 18 to 24.5, 11 to 16, BMI is produced weight gain. So recommended weight gain and total weight gain for single pregnancy according to pre-pregnancy BMI. So management during pregnancy. So perform serum blood glucose fasting and postprandial. Glycemic targets during pregnancy are fasting and preprandial should be less than 95, 1 hour should be less than 140, and 2 hours postprandial should be less than 120. If glycemic targets not achieved within 1 2 weeks, initiate pharmacological therapy. For the first 2 weeks, you can advise unless and until the fasting is more than 126, HbA1c is more than 6.5, you can advise diet modification, lifestyle changes. So for 1 to 2 weeks, you can wait. If it is not under control, you have to start the pharmacological therapy. So insulin first line may use aspart, lispro, glucagon, perinatal outcomes similar with any of the drugs. Metformin may be used as an alternative to insulin, good safety drug in pregnancy. Evidence of less maternal weight gain, less large for gestational age, less neonatal hypoglycemia. Women should be informed that it crosses the placenta. Safety data in offspring postpartum up to 2 years is better only. So insulin necessary in 40% on metformin. So even though you can start with metformin, 40% of people will eventually need insulin. So glyburide may be used in women who refuse insulin and not well controlled with on metformin. So glyburide and metformin are the only two oral agents which can be used in pregnancy. Increased surveillance should be considered in women poorly controlled and or with comorbidities. Offer induction 38 to 40 weeks gestational age to potentially reduce stillbirth and C-section. Earlier or later induction should be considered based on glycemic control and presence of other comorbidities. Management during pregnancy. Healthcare providers should discuss appropriate weight gain health sale. Same thing what I have been discussing. So nutritional counseling is important to reduce high glycemic index foods with low glycemic index foods. So if women with GDM does not achieve glycemic targets within 1 to 2 weeks, with nutritional therapy and physical activity, pharmacological insulin should be started. Insulin in the form of basal bolus therapy may be used as first-line therapy. Rapid acting analog insulin, lispro, glulicin may be used over regular insulin for postprandial glucose control, although perinatal outcomes are similar. Metformin may be used as alternative to insulin. So management during pregnancy in women with GDM who decline insulin and do not tolerate or are inadequately controlled on metformin, glyburide can be used. Fetal surveillance and timing of delivery in GDM. Increased frequency of fetal assessment should be considered women with GDM that is poorly controlled and associated with comorbid conditions. Women should be labor should be inducted at 34 to 40 weeks. So management during labor. Keep maternal glucose between 72 to 126 as discussed earlier to reduce the risk of neonatal hypoglycemia. Monitored regularly. So postpartum considerations. Encourage breastfeeding, reduce neonatal hypoglycemia, childhood obesity, diabetes, and maternal risk of diabetes and hypertension. 75 grams oral glucose test between 6 weeks to 6 months postpartum to detect whether they are pre-diabetic or diabetes. So 75-gram oral glucose tolerance is 6 weeks to 6 months if diagnosed with diabetes earlier in pregnancy. Do fasting plasma glucose and OGTT at 6 to 8 weeks postpartum. Normal healthy behavioral interventions. Impaired glucose tolerance, healthy behavior plus interventions plus or minus metformin. Type 2 diabetes, all the following with metformin and insulin. So the same thing which has been explained. Thank you. So if anyone has any doubts, you can ask.
Everybody are sleeping. Just stand up, no? Once. Yeah. Are you sleeping? No, no. Then sit. Ask questions.
Who is
I want
representing
questions.
women and child? Anybody represents from women and child? Yeah, you have questions?
Gestational diabetes.
Yes.
Sir, if a woman is having gestational diabetes, after delivery, in future, is there any chances to get diabetes for
Yeah.
that woman?
Most of the what they say is it's like gestational diabetes. Almost 15% remain diabetic. So even after pregnancy, they'll have diabetes. Almost 40 to 50%. There is 60% probability that they'll get diabetes in next 5 to 10 years. So out of 100 gestational diabetes uh, patients, 15% may become diabetic after pregnancy also.
In that case, what preventive measures
See,
she
that's
has
what-
to take?
So that's what educational and all these things. Once that's why we have to do these after 6 weeks to 6 months to prove whether they remain diabetic or they become pre-diabetic or not diabetic. So most of the time after 6 weeks, what we call it as post this thing, postpartum and all, perperial period. What once that is done, you have to check for your sugars. If it is normal, healthy lifestyle is fine. If it is borderline, you can continue metformin and see. You have to change your lifestyle, whatever weight you have gained, try to reduce that and all. So even after that, if it persists, you have this diabetes and they have to continue depending upon how bad it is. They have whether only tablets or insulin, they have to use it.
Any other questions?
I want to know what is the probability in percentage to have a child juvenile diabetes if a mother is having gestational diabetes?
So it's not like any compulsory. See, because diabetes is there is no indication or correlation because the mother is a diabetic, babies will get it. So it's all about same thing. If your mother parents are diabetic, there is a chance that the kids can have diabetes in future. But the chance of they having in adult is more probability. Type 1 and all is completely different, genetics and all. So that is a different thing. Just because mother is diabetic, there is no rule or chances, no probability that the kid will be diabetic. But kid has other complications like neonatal hypoglycemia, offspring obesity, because these complications can happen to the baby, but not diabetes. If they have some genetical issues, mother, that probability will be there. It's not like just gestational diabetes won't be causing diabetes to the kids.
Thank you, sir.
Any other questions? Thank you, sir. Thank you for your wonderful explanation.
Thank you all. If anyone doesn't have doubts, I'll okay, ma'am. Thank you.
Thank you, sir. Thank you so much. Now, I'd like to invite Dr. Gayatri ma'am. She's a MD in endocrinology. Ma'am is a gold medalist for the first prize in the quiz competition of pediatric endocrinology, which is conducted in Chennai 2019. She is the winner of Best Paper Presentation prize at Epicon in 2015, winner of second prize at Epicon 2019. Also, she was the best outgoing student person from MBBS in SMC Vijayawada. Ma'am got a lot of awards and medals in the academic career. Ma'am participated and presented many international and national conferences with publications in renowned journals. Now, I'd like to invite ma'am to present the myths in diabetic and insulin administration techniques. Ma'am, over to you. Ma'am is working in Nellore. Ma'am will be joining online from Nellore.
Share already. Yeah. Yeah. Good afternoon, everyone. Hi, I'm Dr. Gayatri, consultant endocrinologist at Medicover Hospitals, Nellore. Am I audible, ma'am?
Ma'am, you are audible, ma'am. You can continue.
Yeah, sure. Thank you. So today I thought we'll discuss about insulin injection techniques and then a little about myths and FAQs in diabetes. So firstly about insulin injection, the challenges, the psychological challenges. Why patients usually refuse insulin therapy? Because this anxiety related to prick, fear of needles, sense of lifelong dependence on insulin, sense of failure to manage one's diabetes, fear of weight gain, low self-esteem and interference with quality of life. So these are the, at least on a superficial level, these are the kind of myths which we need to clear when patient comes to us and
Excuse me, Dr. Gayatri, can you move your slides? Your slides are not moving.
Now-
Share slide you have to do.
yeah, are they moving now?
No, full screen, you just tap the F5 button. Full view screen. Your slides, you're not able to, your slides are not shareable?
Okay, yeah. Now?
Yes, yeah.
Yeah, nice, sure.
Yes.
So yes, as I was discussing this anxiety related to that fear of needle. So firstly, I'll discuss in the further slides about how we have now needles which are finer, which are kind of more painless, and how to make the pricks painless. And then a sense of lifelong dependence on insulin. Insulin is started for a number of reasons. Firstly, when you go to your endocrinologist, they'll first try to find out what kind of diabetes the person has. And in case it is type 1 diabetes or it is pancreatic diabetes, or if there is any other particular reason for to maintain the patient on lifelong insulin, only then it is maintained. Otherwise, there are a number of reasons why patients are started on insulin. for a temporary basis, and then patient can go back to OHA once that reason is ruled out. Like in case patient goes in for diabetic ketoacidosis, which has already been mentioned by sir, or like gestational diabetes, or if patients are admitted for surgery or some acute illness, or like for COVID, like recently for COVID, a number of patients who started on steroids, and when they're on steroids, on tapering doses of steroids, because the doses keep changing, the insulin resistance keeps changing, and in such conditions, it is required to put the patient on insulin, like sir has mentioned beautifully about in hospital monitoring, because the food pattern keeps changing. Especially like patients, if they're admitted for some surgery, the patient would be NDM on one day, and then only on liquid diet for another day, and then on soft oral diet. So because the pattern of food keeps changing, if it is insulin, it is easier to titrate. So then fear of weight gain, obviously there is definitely weight gain associated with insulin administration. But then if there's no other option left, like in case the patient has type 1 diabetes, I mean, there are a few other strategies to combat weight gain, like in type 1 diabetes, like metformin can be added in people who are obese and have type 1 diabetes. There are a number of other strategies, like people with type 2 diabetes, like you can go in for GLP-1 analogs or things like that to combat the weight gain associated. In fact, we even have combined formulations of insulin plus GLP-1 analogs. So documentation, like these were a few issues which I faced here. So I thought like documentation is something to be mentioned. Whenever insulin is being administered, is to be clearly mentioned what is the dose of insulin that is given. Like this is something which happened very recently. When you write 60 units of insulin to a person, 60 units of atrapid subcutaneous to a patient, supposing in the COVID ICU, if it is 60, it has to be written 6 and 0 and no U, not 60 U. It has to be written either nothing, only 60 is to be mentioned, 60 or 60, 60 human atrapid, or 60 UNITS, units completely. A number of people write it as U, and then it becomes very, confusing whether it is U or whether it is that additional 0, whether it is 6U or whether it is 60. So preferably write this very clearly. This documentation is required. And then the dose is to be mentioned. A number of people give insulin and then they might not mention the dose in the insulin chart. So we do not know whether the fixed dose was given or some other dose has been given. So the dose is to be mentioned, the correct dose is to be mentioned, because the same dose that was mentioned in the doctor's orders in the morning in the fixed dose might not be given. And then insulin is to be given irrespective of checking. Simply because a patient is being discharged, if a patient on insulin is being discharged, simply because the patient is being discharged in the afternoon, we cannot send the patient without giving the afternoon dose of insulin if we are offering lunch to him. And whenever we check, do it at the right time. So insulin, probably if the patient has already started eating, control might not be really very smooth, but still you can still give insulin after the meal if the patient has already started taking the meal. But we cannot check at any random time, like half an hour after the meal or once the patient has started taking the meal. It is always to be checked at the right time before or 2 hours after. It is to be checked at proper times. So yeah, sliding scale, like sir has also already mentioned, sliding scale is something which is completely avoided nowadays. And if a fixed dose is given, this is something, if a person is supposedly there's a patient in COVID ICU on steroids who is given approximately 40 units of insulin 3 times. If the person was given 40 units in the night and in the morning the blood sugars have come as 120, the blood sugars have come as 120 because those 40 units were given, not because the blood sugars are normal and we missed that dose of insulin. And then the route of insulin, this is definitely to be mentioned, whether it was given subcutaneous or IV, things like that. The name and type of insulin to be clearly mentioned. Expiry date is to be checked before giving. Then the insulin, the same as prescribed. Like in case Mixtard is written in the night, Actrapid cannot be given. And in case we intend to give Actrapid in the morning, Mixtard is not to be given. So whether the type of insulin that is given, that is the same as what is prescribed. Insulin must be clear. We need to check for any cloudiness. This is something which I'll mention in the further slides as well. So if it is in use, it can be stored at room temperature as long as the room temperature is less than 25 degrees centigrade. But is definitely not to be refrigerated. Not to be if not in use, it can be refrigerated, but definitely not frozen. Refrigerated again in the door. I mean, it is to be in the track in the door, such that the temperature is always more than 4 degrees centigrade. And at least if not in the once opened, within 1 month that particular vial of insulin is to be used up. If not open, maybe you can use it a little longer, but if open, definitely within 1 month of starting usage. And yes, uh, to avoid extremes of temperature, at least for people who are living in Andhra Pradesh, if our temperatures, like I am from Nellore, here we have temperatures above 40 degrees centigrade, and if a person does not have refrigerator at home, what is to be done? If a person on insulin does not have a refrigerator, like even for water, what do? They usually use this pots, water pots, earthen clay pots. So in a similar clay pot, we can put some utensil and put that particular vial on it and close the container. So the same kind of cooling that we provide for water, the same measures that we adopt to for cooling water, the same measures we can use for storing insulin also at cooler temperatures. And the correct method of resuspension of insulin. So whenever we start, this is one way how we talk to patients who are not really educated about when we talk about insulin. Pala lantida, neela lantida. This is what we say. So this actrapid is something which is like water, which is clear, and mixtard is usually it is like palu. It is like milk. It is thicker. So when it is to be resuspended, we usually roll it. We roll it in the between the two hands. We roll it. This is how we can resuspend. Roll it, and from tip to tip 10 times, and then we can visually check whether it has finally become uniform or not. And how to make the injection less painful? Larger dose, definitely. The doses are more than 60 units per prick. Like this is something which we use for basal. If the basal dose is more than when we use 100 IU syringe, and if the dose is more than 16 units, we prefer splitting it into suppose the dose is 80 units or 100 units, we make it 40 or 50 in the morning and 40 or 50 in the evening. So consider splitting larger doses to make that injection less painful. And the insertion of the needle, using a new needle for every injection. Like the best way, the ideal way is to change for every prick, for every single prick, we need to change the needle. But in case they cannot afford, or it is not really, it's not really possible, then at least 2 to 3 pricks, as far as possible. At least this is proportionate. I'll show you a more diagrammatic representation of how every time we keep pricking, how the needle becomes blunter and more painful as we continue with the same needle. So again, these things, when the insulin is removed from the refrigerator, it is cold. So it is good to bring it to room temperature for like a few seconds or few minutes, and then give it, so that that cold injection becomes painful. So otherwise, once we bring it at room temperature, it will be less painful. And finer gauge needles, at some point of time, needles were actually painful, but now we have, at least for syringes, we have 6 mm needles. These 6 mm needles come in 31 gauge, which is less painful. And we now have pens which come with 4 mm needles, and these 4 mm needles are of 32 gauge. So 32 gauge is really thin and kind of painless. And yes, alcohol swab, once we use an alcohol swab to dry the site for giving the prick, we should always see to it that the swab and that part has dried, that alcohol that part has dried, so that it becomes less painful. Otherwise, it still has that alcohol stinks, so it becomes painful. Factors influencing insulin absorption: the size of the dose, physical activity, ambient temperature, body temperature, massaging sites, age, needle length. So needle length I shall be describing in the further slides. So temperature, in fact, that is why if they take insulin injection and they immediately move the limb, or they go in for exercise, that absorption will not take 20 minutes. It would go even faster, which is why they are supposed to take insulin. In case they take in a limb, they are supposed to take in a limb which is not going in for exercise. If they're not going in for, they shouldn't be going for exercise, or in the limb which is not used more frequently. And factors affecting insulin absorption. So concentration of insulin, type of insulin, different types of insulin, like already have been discussed by sir. So concentration of insulin types, the needle length, as I mentioned, that we now have 31 gauge and 32 gauge. In fact, this minimum depth is at least required, because skin thickness itself is 2 to 2.5 mm. So minimum this 4 mm is required, but we should see to it that it is less, and it is not so deep that it goes into the muscle layer. And if the needle is small enough, 4 mm, then we can even give it without the pinch. We lift the skin for giving injection, so we needn't do that here. right tissue space, like I mentioned, shouldn't be going into the muscle, should be left in the superficial, should be left in the subcutaneous fat zone. So if the needle is longer, there is always this risk of IM injection. Again, this is proportionate. If the needle length is only 4 mm, then the probability of IM injection is only 0.4%. Whereas if the needle is long, 8 mm, we have to give it at an angle. Otherwise, there's this risk of IM injection up to 15.3%. IM injections more frequently occur with longer needles in thinner, slimmer patients, in younger patients, in males, and in those who inject into limbs rather than truncal sites. Again, so which is why I mentioned for such patients, you should always give at an angle. If inserted at 90 degrees without the skin fold, then this is how there's every possibility that the injection goes into the muscle. So shorter needles can be given at 90 degrees, longer needle preferably at 45 degrees. The correct way of performing a skin fold, this is how the fold should be. Not very thin that only the skin is lifted and not the subcutaneous fat part, and not very thick that the whole muscle is brought into that page. So that is how the skin fold is to be taken. Sites of insulin injection, the upper outer part of the arms and the thighs, and leaving a 2 centimeter, 2 finger width around the umbilicus in the abdomen on both sides laterally, also on the buttocks. And the rate of absorption is usually faster in abdomen and the slowest at the buttocks. And side rotation, it's always preferable to, in fact, it is mandatory that sides are always rotated. So that way we can prevent lipohypertrophy and maintain healthy injection sites. So you can divide the injection site into quadrants. Like for abdomen, you can divide it into quadrants or halves. And then that way, if today in the morning, if you've given it here, then for the next time we can give it here, like here. So that way we can keep changing the injection site. So one quadrant for 1 week and then move in the clockwise or anti-clockwise quadrant to another quadrant or another half in the next week. And 2 sides should be at least 1 to 2 centimeters apart from the previous side. And do not inject in the area of lipohypertrophy. Yeah, this is something. Do not, or infections definitely, or an inflamed area. So if there is lipohypertrophy, what happens is, whenever there's lipohypertrophy, that part is thick, and irrespective of how much ever insulin you give, it would appear that that quantity of insulin is not working, and then we would keep going for higher and higher doses. And at some point, if someone realizes and gives the same dose at some other site, the patient can actually go in for hypoglycemia, which is why it is required that we don't let lipohypertrophy set in. And even in case lipohypertrophy sets in, we shouldn't use that site for injection. Similarly, if the patient has any inflammation or infection at that area, then that area can be much vascular and it can cause much rapid absorption than is predicted. Insulin injection technique. So firstly, we'll check that these things, like we've already mentioned broadly, we will check the expiry date, the type of insulin, ensure that there is sufficient insulin in the dose, resuspend it properly, attach a new needle, and prime the device so that any air in the device, any air in the needle, in the pen is removed, and after that, then we dial the desired dose and then we give the insulin. Choose the appropriate site, and then if it is like 4 mm needle, then we can give it directly without the pinch as well, and you can give it at 90 degrees angle. And once you give, count minimum 1 to 10, even 1 to 30 is still better, at least 1 to 10. And yes, disposal of needles. Needles are to be disposed very safely, or in case they do not have any method for disposal, they can save those needles. And whenever they come to the hospital, they can discard in the containers which are earmarked for needle disposal. Never leave the needle attached to the pen because like air bubbles can form and then insulin also can leak out. Again, whenever we injection through insulin syringe, wash the hands, wipe with alcohol swab, and then when we draw air, we will draw air also, and that way, so that when you push or when you pull, there is no vacuum created. So you draw air, you push that air part into the vial, and then draw the insulin, and then then administer. Sorry. Pregnancy, first trimester, because in the first trimester it is still in the pelvis, the fetus is still in the pelvis. So we needn't bother about change of sites. In the second trimester, preferably lateral parts, and in the third trimester, by properly lifting the skin fold. In case the patients are still apprehensive, you can go in for the other sides, arms, thighs, or buttocks. Lipohypertrophy. Yeah. So all these lumps, lipohypertrophy is thick, soft to foam swelling with rubbery consistency, which appears on the surface of skin at the site of insulin injections. In fact, we had this media needles people conducted a workshop which we attended. They have demonstrated how, in case you simply palpate, whenever a person comes and says that the dose of insulin is not working or they have frequent hypos, you can always check the patient whether they have any lipohypertrophy. One way of doing it is, firstly, we would directly palpate and see. In case you cannot find it, you can actually rub some jelly on your hand or on the skin and then check. That helps in easier identification, and that picks up a few lumps which are not identified by directly palpating. So it appears as a raised swelling which cannot be pinched together. So that can cause hypos, and more importantly, like this, the concept which is coming up nowadays is glycemic variability. So not merely hypos, but it would cause a lot of glycemic variability. Hypos when it is injected in any other site, and hyperglycemia with no response when it is injected on the sites of when insulin is injected in those places of lipohypertrophy. So in case there is lipohypertrophy, 49% of patients, like in a particular study published in 2013, 49% had glycemic variation compared to only 7% who did not have lipohypertrophy. And similarly, 39 patients had hypos and compared to only 6% who did not have lipohypertrophy. So this 25% reduction in insulin absorption with the presence of lipohypertrophy. Moreover, people who have lipohypertrophy, because there is improper response, higher doses of insulin are used on an average, and this again accounts for some economical burden as well and a lot of inconvenience to the patient. So this is how we check for it visually, and then we can also palpate and check. And inspection site should be inspected at every visit. Patients should also be taught to inspect their own sites and given training on how to detect lipohypertrophy. Needle reuse, like I mentioned. New needle is sharp. Use once, a little blunting, twice, a little more, 6 times, totally blunt. So this totally blunt needle would be painful, which is why it is always preferable that the needle is changed as frequently as possible. So needle reuse, pain, bleeding, bruising, lipohypertrophy, more prone to lipohypertrophy, contamination, infection, dose inaccuracy, taking off and lodging under the skin. So it can cause laceration, and residual insulin can be left, which can crystallize. Safe disposal, never recap, use pliers, or in case all of this is available, it's okay. Otherwise, these empty devices can be either disposed of in household bills, or can be brought to the hospital and disposed of there whenever they visit the hospital. So summarizing what is to be done: check the type of insulin, check the dose of insulin, document it properly, check the expiry date. Use pinch up if the needle is not small enough. Then maintain the site rotation. Discard used needles properly. Check your blood sugars and give insulin appropriately. Do not freeze. Do not use beyond 1 month. Do not massage these injection sites or go in for exercise. And preferably not to reuse. A few myths about diabetes. I'm sorry. Yeah, so a part of it is a collection of my personal experiences about what patients say when they come to me. Whether sweets are banned, whether banana is banned, whether rice is banned, whether once they have diabetes, whether they're not allowed to take rice. So there's nothing like one thing which when I had initially joined DM, a nutritionist had told to us one nice thing, bottom line, that there's nothing basically called a diabetic diet. It is the ideal diet to be followed. So there's nothing like anything is actually banned. It is only because your blood sugars are not cooperating, or it's only because the pattern is in such a way. About bananas, actually, our professor used to say that monkeys depend on bananas, but it's not like all monkeys going for diabetes. So there's nothing like one particular item is banned. It all depends on the glycemic load, on the glycemic index of the food, and how the insulin resistance of the person is, and depending on that, we would change the meal accordingly. These are not blanket statements for everyone. And when people say that they don't mix sugar in their tea, but they go in for rice in the afternoon, that is what they say. That when you're eating so much of, when you're taking so much of load, so much of glycemic load during your lunch, that one spoon of sugar might not matter much. You concentrate on those main meals. This is not something which is the problem there. That is one thing. And then when they say they only eat tiffin at night, tiffin has to be very clear. When I say wheat-based item, it has to be wheat-based item and not idli or things like that, which have a very high glycemic index. They do not count as tiffins at night, and not, at least definitely not to be taken at night. And this diet foods, this faddism about diet foods, there might not be much advantage with the usage of diet foods, because not all diet foods are zero calorie foods. A few of them have calories, maybe lesser calories, but they do have calories. They too can contribute to hyperglycemia. A few of them have laxative properties, and then they're expensive and might not be worth the investment. Then a number of people say that they use jaggery or honey. Not a good, not any great advantage, because they also contribute to hyperglycemia. And jaggery, in fact, has the same glycemic index as sugar. So they do not have much of an advantage. If sugars are to be avoided, then jaggery and honey is also to be avoided. Then people say that they missed insulin because they were not eating. Because like sir discussed, that liver produces some basal, there's some basal glucose production by the liver itself, by gluconeogenesis through the liver. So blood sugars can still be high, and even if patient is fasting, insulin might still be required. Again, like I discussed, insulin is not permanent for everyone. For a few patients, we started temporarily. So once started, it's not continued for life. I do not have diabetes. A number of people say that I do not have diabetes. Probably they haven't tested themselves for diabetes, or they feel that they're not in that risk zone. So I think this was already mentioned by sir, but a quick recap of these criteria for testing for diabetes in symptomatic adults. So basically, Asian Indian ethnicity, we call this the Asian Indian phenotype or the YY paradox. For a person with, this was seen in Yagnik and Yudnis, for these two people, when they were one Asian and one Caucasian person, when both of them were compared, even with the same BMI, when we look at the body composition, Indians have a greater fat percentage. So, which is why the Asian phenotype, the Asian Indian phenotype is not favorable, basically, for diabetes, which is why these people, basically, this is the very first risk factor for diabetes. Other than that, if they have first degree relatives with diabetes, or hypertension, cardiovascular disease, HDL cholesterol less than 35, triglycerides more than 250, PCOD, physical inactivity. What is physical inactivity? If the expenditure is less than, if their physical activity is such that the metabolic equivalents of less than 3 to 4 are being consumed. If they have markers of insulin resistance like severe obesity, acanthosis nigricans, and the skin tags, those with pre-diabetes, those who do not have any of these risk factors, they are to be tested at 45 years of age and every 3 years thereafter. But then if they have pre-diabetes, they are to be tested yearly. And if the GDM, immediately after the delivery also, they need to be tested from there. Not, we wouldn't wait till 45, from there once in every 3 years. And then HIV. Again, people with HIV are to be tested for diabetes. And children, those who are overweight with BMI more than 85th percentile, or obese with BMI more than 95th percentile, if they have risk factors like if the mother had diabetes or GDM during the child's gestation, or there's a family history of diabetes in either first or second degree relative, then race, and again markers of insulin resistance or other conditions like small for gestational age child, these children also are to be screened for type 2 diabetes. Again, like this was already mentioned, what is how we diagnose diabetes. So in case this is a person who has come to you with a myocardial infarction, patient who is admitted with myocardial infarction and sugar is more than 400. So would you brand the person as diabetic? Okay, other than the fact that there can be something wrong with the glucometer, they may or may not be having diabetes. It could merely be stress hyperglycemia. We would continue to monitor the patient. Not that we would not treat that hyperglycemia, we would definitely treat, even if it is stress hyperglycemia, even if the patient has, supposing coming with some TIA or some CDA, we would definitely treat the patient, because again, that is euglycemia is required to protect the neurons. We would definitely treat the patient, but then it could merely be stress hyperglycemia. So not all of them are branded as type 2 diabetes or diabetic. They can merely have stress hyperglycemia, or the other conditions are like steroid induced hyperglycemia, or like even if we don't, if it is not fasting or postprandial, if we check a random blood sugar, only if it is associated with osmotic symptoms, then that one value of 200 can be considered as diabetes. Otherwise, we would have to recheck all of these values. If it is unequivocal, we need 2 abnormal values to confirm that the patient actually has diabetes. But if these patients come with sugars of 300 and they say that they don't have diabetes, they actually have. So, okay, this part of it. What kind of diabetes it is, that is to be checked. And like this was already mentioned by sir, if they have pre-diabetes, for the diabetes risk, we have this Indian diabetes risk score. And other than that, there's something else called the Ramchandran diabetes risk score. So at least one thing is for sure, when we talk about waist circumference, even for metabolic syndrome, we say that waist circumference more than 18 female and more than 19 male is considered metabolic syndrome. But there was one consensus statement which was published in JAPI by Shashank Joshi et al., in which they had done a study and had mentioned what were called action thresholds. And according to this consensus statement, it was told that the waist circumference of more than 72 centimeters in a female and more than 78 centimeters in a male is considered action threshold. And in case we do take any action, in case we increase the physical activity or have some lifestyle modification, dietary modification, we can see to it that the patient doesn't go in future for metabolic syndrome or for diabetes. So again, the other myths or the other FAQs that people say that the people going for hypos every day and they're comfortable with it. So we should change the insulin, and we now have newer insulins which see to it that there's less glycemic variability, that they're less hypos. We now have peakless insulins, what are called peakless insulins. So we need to put every patient on combinations of NPH, like in split mix or premix. We can counsel the patient and we can go in for glargine or degludec. And then, so people who eat heavily on powerful medications, it's preferable that they eat a little less and take less powerful medications so that we are not contributing to the progress of diabetes. Symptoms to identify diabetes. There can be symptoms to identify hypoglycemia, but I wouldn't say that there are symptoms. You wouldn't depend on symptoms to diagnose hyperglycemia, because by the time they present with symptoms, it may or may not be an early stage. Of course, we always say that there are osmotic symptoms of polyphagia, polyuria, polydipsia, or like UTI or other varieties of frequent infections and weight loss, things like that, which are markers which can clinch identify the diagnosis of diabetes. But it is always good to go for screening and identify it in all the more early stage. So then a number of people say that glucometers are anyway unreliable. Glucometer is to be, once a diabetic, at least broadly diabetic for life. I will again give some contradictory statements in the further slides, but as of now, broadly blanket statement is once a diabetic, diabetic for life. So they should always be having a glucometer at home for any kind of emergencies. If they say they are unreliable, go for a proper glucometer. So we have varieties of glucometers. Then there were a few studies which were conducted to see the mean absolute relative difference. This is how we look at the accuracy of glucometers. And if the value is less than 9%, these machines are considered more or less accurate. So the ones which come highest ranking in this are Condor machines, AccuCheck, OneTouch, and Freestyle. So again, a few variants of these, not all of this, a few variants. Condor and OneTouch actually, a few models actually have marked of less than 7%. But then I think they are very costly variants. In general, usually AccuCheck, a few OneTouch ones, and Freestyle again not really very freely available. But AccuCheck, things like that, these are something or Condor in general. These have low MAR, and these can be comfortably prescribed for people with diabetes. So temporarily had diabetes, for those who say they stopped medication because after normalizing, they normalized because they were on medications. No one in the family has diabetes. Basically, so people cannot say that nobody has diabetes, so they might not be getting, because the background baseline prevalence itself is 10%, 10% for diabetes and 10% for pre-diabetes. So overall 20% is the prevalence, even if 10% are undiagnosed, even half are undiagnosed. So almost pre-diabetes, diabetes risk is 20%. So general risk itself is that much. And if the mother has diabetes, still mother or father, if one parent has diabetes, 40%, both the parents have diabetes, 70%. So very bad risk. So if they, some people they say that they cannot keep eating multiple meals per day and they want one heavy meal, then sir has already discussed. We now have Lispro, Aspart, still better. We now have things like Fiasp, ultra rapid acting injections, which can be eaten, which have very short duration of acting. So whenever they have that mega meal, they can take with that. Those who say that they cannot keep pricking for multiple tests, we now have CGMs. We have continuous monitoring systems, yeah, so we have a number of advances. I shall discuss a few of these advances. So for painful pricks, we've already discussed those 4 mm 32G needles. And then we even have insulin pumps if they're comfortable with it. And yeah, a few people who are very, who say that they want perfection. If they say that every time the sugars change, how do I give that change dose? And if they want everything to be jotted down, if they do not want. So for that, we have CGMS. So I'll discuss a few of those things. Now we have, for pens, we have Bluetooth enabled insulin pens, smart pens. So these things, they have the ability to record the dose and the time of insulin delivery. And they have built-in bolus calculators which help in insulin dosing calculations. So they would record the dose so that you get to know that what was the blood sugar in the morning or what was the dose. If you, because blood sugars again would be documented. We now have glucometers which document the doses, which have this Bluetooth connectivity, and that way you can have those values in the phone. And then your machine itself, your Bluetooth pen itself, insulin pen, would record the dose given, and that way it itself would calculate how much dose is required for the afternoon meal as well. Then we have pumps. Indications for insulin pump: if there's so much of glycemic variability and you want to know where things are going wrong, or you want to give insulin proportionately, depending on whenever there is hypo or hyperglycemia, elevated HbA1c, glycemic variability, recurrent hypos, nocturnal hypos, activity-induced hypos, recurrent decay, hospitalizations, a large total daily dose, mealtime flexibility, gastroparesis, inability to self-administer insulin, or inability to predict food intake. This is about CGMs, which I was mentioning. So we have these few parameters. CGM metrics, the one which is readily available for flash glucose monitoring. We have continuous glucose monitoring and flash glucose monitoring, real-time monitoring and continuous monitoring. So for that we have like at least Freestyle Libre Pro is something which is freely available, easily available. So that can be used up to 14 days. And the percentage of time it is active, at least 70% of the data is to be taken. And from that, we can calculate what is called the glucose management indicator. Glucose management indicator is like the new HbA1c. You needn't wait for 3 months to calculate your HbA1c. This is your short-term HbA1c. So for those 14 days or for the 7 days that the person, only in 2 weeks, you can directly get how the HbA1c would be if the patient maintains that kind of control. Then you can calculate the glycemic variability as well. The target is that the glycemic variability should be less than 36%. You can look at time in range. Time in range is something which again is a marker of glycemic variability. So the time in range is 70 to 180. We would look at the time for which blood sugars are being maintained between 70 and 180. Time above range, above 180 or above 250. Time below range, less than 70 and less than 54. So then we have targets for all of these. Like for time in range, if the patient is having type 1 or type 2 diabetes, time in range should be more than 70%. That is, they should be the time in range duration should be more than 16 hours 48 minutes. That is, the range is 70 to 180. If they're older patients or high risk patients, moribund patients with type 1 or type 2, we can maintain time in range at least for 50% of the time. That is for more than 12 hours. Time above target, and then so time below target. For time below target, target range of less than 54, type 1 or type 2 diabetes, only 1% of the time, only for less than 15 minutes, patients can maintain less than 54. More than that is not advisable. Similarly, blood sugars are less than 70%, time below target, and maximum duration allowed is only 1 hour, so 4% of the time. In older or high risk individuals, you should never allow these patients to go in for blood sugars of less than 54, and even below 70, only 1% of the time, that is less than 15 minutes, can be maintained at these blood sugar values. So time above range, sorry for the typos. So time above range for blood sugars of more than 180. So this can only be maintained for less than 25% of the time, less than 6 hours, and above 250 can be maintained only for 5% of the time. That is for less than 1 hour 12 minutes. For older patients, again more than one, because we are a little lenient here, we can allow blood sugars of more than 250 for 10% of the time. That is for up to 2 hours and 24 minutes. So again, those targets that we've discussed: 70% time in range, 25% plus 5% time above range, 5% time below range. Older individuals less than 1% time below range, 50% time in range, 60% time above range, such that 10% is above 250 and 50% can be maintained between 180 and 250. Pregnancy, again 70% time in range for type 1 diabetes, 25% above 140, 4% less than 63, and 1% less than 54. For pregnancy, like gestational diabetes or type 2 diabetes, a target range of 63 to 140 range. This is something to be maintained, and for a very less duration of time above range or below range. Because type 1 are more prone for hypos, they can go in for hypos, and this is something they usually have a little kind of diabetes. We can be strict with diet modification and things like that. In the type 2 diabetes, we can maintain stringent control such that most of the time they are in range. Then we now have glucose responsive insulin delivery systems. That is, you can have insulin pump and CGM, sensor augmented insulin pump, that can automatically suspend insulin to prevent hypos. So automatic suspend. And then we have hybrid closed loop systems, which can actually be called the artificial pancreas. That is, they modulate insulin delivery greater or less than the preset rate based on the sensor glucose levels to mitigate both hyperglycemia and hypoglycemia. So we have pumps which give glucagon when patient goes in for hypo, or we can say, which can simply suspend insulin administration when patient goes in for hypo. Hypo is kind of the reality of life for people with diabetes in case they are on agents which can cause hypoglycemia. For any person who strives to see to it that blood sugars are under control, they can always go in for hypo. But yes, because hypo is something which is life-threatening at that point of time, we should always see to it that they don't go in for hypo. But again, blood sugars, stringent control of blood sugars to be maintained. Then a number of people say that thyroid issues have caused weight gain. If the patient really had hypothyroidism causing fluid retention, which can contribute to weight gain, that would be a maximum of 3 to 5 kg. All the other thing is probably because of decreased that will to do physical activity, or that is again not related to hypothyroidism per se, due to the water retention per se. Why do you test for lipids, cortisol, ONDST? So we always need to, whenever they go to an endocrinologist, you always need to rule out secondary causes, at least history-wise, or if there is anything suspicious, we would go for investigations and rule out any other secondary cause of diabetes. Because there are a number of causes for diabetes. Other than the simple type 1 and type 2 that we know, or the gestational diabetes, there can be MODY, there can be LADA, there can be pancreatic diabetes, or there can be diabetes associated with acromegaly or Cushing's disease, or things like that. So it's always required that we rule out secondary causes and treat accordingly. Is there a maximum dose of insulin? Many people ask whether there's a maximum dose of insulin. There's nothing like a maximum dose of insulin, depending on their insulin sensitivity. In fact, textbooks mention that there are people who have been given more than 1 lakh unit of insulin per day for people who have lipodystrophy. Is there a cure for diabetes, or can we prevent diabetes? For type 1 diabetes, there were a number of prevention trials, a few of which George has already mentioned, with oral or intranasal insulin, with avoidance of casein, or with usage of nicotinamide, abatacept, teplizumab. Teplizumab is something which is now in the news. Rituximab, botulinum. None of them is, at least as of now, approved for commercial use, BCG and things like that. Number of agents are being tried for prevention of type 1 diabetes, for secondary prevention, in case they are antibody positive. And we want to, and they still haven't gone in for dysglycemia. Type 2 diabetes, there's this one upcoming concept for reversal called type 2 diabetes remission. That is, they have to maintain their remission for a minimum of 6 months with only lifestyle modification without any medications. But then it doesn't mean that the patient has gone in for CKD and therefore is maintaining euglycemia of insulin. So without complications, the patient has gone in for remission for more than 6 months. It can be considered remission or reversal. We now have scoring systems in whom this can be tried. So we have this ABCD E4 score. ABCD is age, BMI, C-peptide, and duration of diabetes. So if the age is less than 40 years and BMI is more than 42 kg per meter square, so they're really obese, and C-peptide levels well maintained more than 5 millimole per liter, and duration of diabetes less than 1 year, these people on the right side end are perfect candidates for weight loss and for the bariatric surgery, things like that. And these people, if we want, we can attempt reversal in these people. So score more than 6 predicts remission in patients with diabetes. Other than that, the other things which contribute are E4, expertise of the doctor in seeing to it that the patient goes in for remission, enthusiasm of the patient to adhere to that those low calorie diets and contribute to their weight loss, engagement between the doctor and the patient, such that they come to the doctor for frequent monitoring and see to it that they are compliant. Euthymia, a happy mood. They should be happy about their weight loss and that their diabetes is going back and not that they are depriving them of things that they like. So other than that, the agents which are being used, sir has already mentioned a few things like acarbose, voglibose, metformin. SGLT2 inhibitors are also being used, pioglids, or either individually or in combination, then bromocriptine, pramlintide, low calorie, very low calorie diets. Bariatric surgery is definitely. Usually, we need to attempt weight loss of a minimum 5 to 7. 7% is something which is considered basic. To 15% at least, like 15% is a very good weight loss, which can help in remission. Thank you.
Any doubts regarding this? I think ma'am has sound is not. Any doubts regarding this? I think ma'am has explained all the things regarding all the myths, what we are daily listening from our home and all. Anyway, thank you, ma'am.
Yeah.
Thank you, ma'am. Thank you for your wonderful session.
Dr. Gayatri, just give, we would like to take one snap. Just speak. Yeah. Really, Dr. Gayatri, you have covered very well all the, insulin management, how to dealt about in patient care. So still open to the forum. Any nurses, if they have any questions, post on chat box. She's ready to answer. Either you can, take up further session also. So anytime she's ready to help us to answer our questions. Offline viewers, online viewers, okay. Thank you so much, Gayatri. Dr. Gayatri, you put so much effort to, explain very well, beautifully. You put in one nutshell and very well you have, it's a very good eye opener for my nurses how to deal with, administration as well as part of insulin therapy. Thank you so much. Yeah. I think no more questions. Now I would like to call upon Mr. Uma Maheshwar and his team. Okay. Molekin company, since morning they were with us, behind the screen. Okay. Off screen online viewers, you should know they were, so much of effort since morning they was with us, and relentlessly this company is supporting us, many activities, especially academically. They are very strong, and they used to support for each and every nursing fraternity throughout the, whichever hospital, not only for product basis oriented, they have hands-on trainings with wound care management. Last month, 2 sessions we had with the company, and nurses are very much benefited with those products, and patients also, especially when you're dealing with diabetic foot ulcers, or when you are dealing with wound ulcers, and when you are dealing with the decubitus ulcers, and you have stage 3, stage 4 pressure ulcers. We have lot of many products and lot of supportive care therapy they have dealt with us. And I would like to call Mr. Napoleon and his team. I would like to introduce about their products and give a self intro about their company and what kind of care will help us, especially rehab therapy on wound care management. Each and everything they dealt with us now. So now open to you, Mr. Napoleon and team. Uma Mahesh, kindly come and join and talk about your product. And last but not least, anyhow, Mridula will tell that. But so much support. We had very good, delicious lunch sponsored by them, and since morning, we were waiting. Our nurses are very energized with a lot of boosting by this delicious breakfast and lunch. So I would like to call upon Mr. Uma Mahesh and Napoleon to take over the podium. Thank you.
Thanks a lot for your kind words, ma'am. We are here with my crew here. My name is Napoleon, and I have my sales managers, Mr. Sonu, Mr. Uma, and Ms. Risti and Nitish. So today, our agenda includes a small questionnaire, a review questionnaire, and followed by that, we have introduction about the company. I think some of you are familiar. However, it is a short a presentation about the company. After that, we have an activity where we divide you into groups, and we'll be giving 5 minutes so that do not worry, it's not a presentation as such. And followed by that, we have a product demonstration. In fact, in other words, solutions for a diabetic foot ulcers. All right. So meanwhile, can we divide you into groups, 3 or 4 groups? 3 or 4, however you are comfortable. It's already, however, all right.
And
So
we can shift there, join them only. So yes, like that only. Team 1, 2, 3, 4. You three can join.
however you're comfortable. There's no hard and fast rule that you should be like this or like that. As long as you are into groups, that's fine. We'll be giving you a case study, and we'll be expecting some of you to come here and present. When is the WDD, World Diabetes Day? Tomorrow, yes. Tomorrow is Sunday, so we are conducting this program today. All right, so here ready. We are ready with the questions here, the review questions. So whoever knows the answer can raise up, or in fact, you can actually answer the questions. Post these questions, we'll do the company introduction and we'll start the activity. All right, here we have the questions. So the first question is, the diabetic foot ulcer is of dash types. How many types of diabetic foot ulcers are there? 3, right? Very good. All right, the second one, diabetic foot ulcer present on the metatarsal head. So can you categorize what kind of a diabetic foot ulcer is it? Is it a neuropathic, ischemic, or neuroischemic? It needs to be scrolled. Ischemic? Neuroischemic, all right. See, there are only 3 options, and if you select 3 options, how would I tell you what is correct? It's neuropathic because, all right, let us understand the location of the ulcer. It's happening on the pressure bearing area, right? The metatarsal head. So when the patient has a sensory problem, there is pressure built up and that causes the damage. So it is a neuropathic ulcer. The patient will lose the sensation. So continuously, the patient may remain, or the person may remain in the same position, leading to ulcer on this pressure-borne area or weight-bearing area. All right? Is it clear? All right. Diabetic foot ulcers are chronic, acute, or depending on the healing of the wound. I think no question can be as simple as this. I mean, I feel so. Depends on the patient. I mean, I have kept it wantedly the option as depends on the wound healing. However, it is actually a chronic ulcer. Diabetic foot ulcers are chronic, which takes longer time to heal because of the pathophysiology itself. I mean, the etiology of the ulcer itself, and the other reason being the higher levels of glucose, which takes longer time to heal. All right. I know it can be little not convincing, but usually diabetic foot ulcers are chronic. All right. Okay. Infected diabetic foot ulcers should be cleaned with betadine for reducing infection. False or true? False, 100%. True? False, yeah. Well, like Wi-Fi classification. Can you tell me the option 1, 2, 3? 3. All right. 1. All right. The option is 2. Yes, 2. Wound ischemia and foot infection. This is what is explained by the vascular surgeon. I mean, this is what it is, and it is explained by the vascular surgeon in detail, isn't it? All right. Loss of pain and sensation of foot is neuropathy, ischemia, or none of the above? Neuropathy, all right. Debridement is dash approach. The debridement surgery, is it a proactive surgery or a reactive surgery? Reactive surgery, right? All right. Thanks a lot for your active participation. So here we end the questionnaire for the review of the DFU, diabetic foot ulcers. So now we'll start with the company introduction and followed by that activity and product demonstration. All right. All right. Meanwhile, I'll start talking about the company. So company is pronounced as Monlyke, although it is written as Molnlycke. The L is silent, so it's pronounced as Monlyke. And it's from, any guess where is the company from? Because I know that some of you are familiar in terms of company introduction and other sessions. I see faces who have attended earlier also. Yes, any guess? Accurate. It's not a guess, actually. It's an accurate answer. It's from Sweden. So, in fact, the all right. Okay. All right. So, the company is founded in 1849, as you can see here, and the headquarters are from Sweden, Gothenburg, actually, which is just nearby Sweden. I mean, the Monlike. It's named after the place, after place in Sweden. And there are about 100 customers and about 40 countries we own our operations. All right. So coming to some details or facts about the Monlike, here we notice about 400 pairs of biogel gloves are being manufactured in per every 1 minute. So biogel gloves are something where the gloves color change if there is a prick or a poke in the gloves. Is that clear? So during an invasive procedure or any procedure when there's a possibility of puncture to the gloves, these gloves change the color. So it is evident or noticeable by the healthcare worker who is doing that particular procedure. So these are called as biogel gloves. So that is about this. And there are about 8 lakh components of surgical trays are being manufactured within 1 day, which means Monliki in other countries or other than India, it's into surgical trays. I think all of you are familiar with surgical trays, right? There's a lot of equipment and drapes. So a lot out of the coming to this, they manufacture about 8 lakh different components of the trace in one day. And the last one, if you notice, every 3 seconds, the molecular drape is being used in one or the other part of the world. All right, during for the surgeries. Coming to India, in India, we're into advanced wound care. So in terms of wound care, we are into pressure ulcer prevention. We are also into surgical management, which means the post-operative wounds, and also antimicrobial, which means the infected wounds, which is specifically related to today's program, which is the diabetic foot ulcer. Most of the diabetic foot ulcers tend to be infected. All right, so we have solutions for all these different kinds of wounds. Not limited to this, but we are actually broadly categorized into these three. All right, now here ready with a group activity. So what are the groups? Can I have an idea which is group one, group two? One is that 2 rows are one, right? This row is one. All right, okay. So 4 groups or 3 is also all right if they are okay. It's up to. All right,
So first group from Mallesh, and second group is Anita and Ramya. And here, first group is Mallesh. What's your name? What's your name? Charan. Third group. Sorry, fourth group is Charan, and third group Kavita. This is fourth. That is third.
yes, she needs to be involved. Yeah.
Third.
All right. So I'll explain you what is expected. So this is the first group. We name this group as an exercise. All right. The name of the group is exercise. So who is the first group? Can you all please raise your hand? All of you. So your group name is exercise, as you can see here. And this is a case study. I think you received a hard copy of this one, right? Yes or no? So should I explain in detail, or I think it's there in your hands, right? Everyone has a copy of it, right? Yes or no? Did you all receive a copy or not? All right. So I'll tell you what is expected. What are you supposed to do? So I'll give you 5 minutes for all groups so you can discuss, and after that you can come here and start presenting. It's up to you whether you'll come as an individual person or a group people. It's up to you, but you should come here and present. Is it clear for everybody? All right. So what is expected is as simple as you see here. These are the parameters which we would like you to present. So by looking at the case study and the image, you need to come up with these details. What kind of a wound it is? Is it a road traffic accident, or is it a burn, or is it a pressure ulcer, so on and so forth. And then type of wound, which means if it is a pressure ulcer, for example, please pay attention here, but otherwise it is difficult for you to actually answer it. Is it clear for everybody? Please pay attention for a moment, all of you. So type of wound is it a grade 2 pressure ulcer or grade 3 pressure ulcer? If it is a pressure ulcer, is it clear for everybody? And coming to exudate amount. So exudate amount is whether the exudate is mild or moderate or severe. Is it clear for everybody? Yes or no? Now the other parameters include dressing selection. So will you select a normal dressing or an advanced dressing, or do you want an antimicrobial dressing, etc.? Clear? And the last parameter is management of wound in detail. The medical or nursing management, everything in detail. Is it clear for everybody? Yes or no? All right. So this is the first. Yes, just please make a note on the paper so that it's easy for you to describe or present here. 5 minutes for presentation and 5 minutes for discussion. Is it clear for everybody? Do not worry, I'm here. I'll come to each group and explain you, not the answers, obviously, but what are you struggling with, or what are you not clear with? Is it clear, yes or no? All right, okay. So we'll put a timer for 5 minutes and we'll tell you when to stop. So it's 5:16, so 5:21 you should be ready to present. Group 1 should be ready to present by 5:21. But other groups, please pay attention so that you can be benefited. It's not that only one group is presenting, so you should not concentrate on what they're presenting. 521.
Team 1, your time is up. I would like to ask Team 1 to present now because we are lacking time. So we can start the presentation with Team 1. No, if we will ask like that, then everyone is, I mean, nobody is ready. So that's why I'm asking, whatever you have prepared, please come and present that much only. Please, team one, come forward. Team one, please come forward. Please come. We will display. We will display your case here. Please come. You can join. Please come. Whole team can come. You have done. You have solved this case. Please come, everyone. Please come because this is a group activity.
Okay, okay.
Team, please come and join.
మొత్తం చదివితే నేను ఇది ఎక్స్ప్లెయిన్ చేస్తాను ఓకేనా అంతేగా మొత్తం అంటే మన క్వశ్చన్ ఎక్సర్సైజ్ చెప్పేసి మొత్తం చదవాలి
My topic is exercise. Miss Maggie, 22 years old, was diagnosed with type 1 diabetes. It is uncontrolled diabetes, developed wound on the plantar surface of foot, wound size 2 centimeters long, 2 centimeters width. Wound bed appears red. The classification of the wound.
Parameters need to be observed. Classify the wound. This is the diabetic wound and type of the wound. According to findings, this is type 2, grade 2 diabetic wound. Exudative amount is moderate. Dressing selection, what we have to select dressing. Antimicrobial dressing has to be done. Management of the wound in details wise. Sugars has to be controlled to avoid the further management, further complications. Next, we have to follow the prescribed antibiotics, daily dressing, and we should follow daily food care and keep food clean and dry, and we should follow the diabetic diet. Thank you.
Can you all please pay attention here? Here, they have actually done very well, except one thing I want to tell. Classify the wound. It is a diabetic foot ulcer. They have done it correctly. This is the case study they are given with. Second one, type of wound is it ischemic ulcer or neuropathic ulcer or neuroischemic ulcer? That is what is expected. So what do you think it is? Is it neuropathic ulcer or ischemic ulcer based upon the location? Neuropathic, it is 100% neuropathic because it's on the pressure area, right? Weight bearing areas because of the problem in the sensation. So it is neuropathic ulcer. Otherwise, very good. Yes, can we call upon team 2? Team 2's name is weight reduction.
Our topic is regarding weight reduction. Miss Olive, 44 years old, was diagnosed with type 2 diabetes, reduced physical activity due to weakness, developed wound on the great toe of foot. Wound size is 1 centimeters length and 1 centimeters width. Wound bed appears
Please
black.
pay attention, others here.
So coming to the classification of the wound, it is a diabetic wound, and the type of wound is eschar. Exudate amount is it is a dry wound, so it does not have any no amount is there. Dressing selection is antimicrobial dressing. Management of this, first of all, they have to control the diabetes, and then debridement can be done, and regular exercise according to their convenience. Regular dressing required.
Very good. Can we please give them a big round of applause? But again, the same thing, type of wound, is it a neuropathic or ischemic or neuroischemic? What do you think? Based on that location, is that a neuropathic diabetic foot ulcer or a ischemic ulcer? Is it neuropathic or ischemic or neuroischemic? If the ulcer is happening on the great toe. Very good. So it is ischemic ulcer because ischemic ulcers happen on the toe in between the fingers, right? Is it clear for everybody? Very good. Thank you. Team 3, is team 3, where is the team 3? May I call upon team 3 here to present? How about others? Please come and support your team leader. So your group name is Adequate Sleep.
Classification of wound is diabetic honey wound.
You can actually read out so that others can practice.
Yeah. Okay. I got a case of Miss
Please pay attention,
Velvet,
others.
53 years old, was diagnosed with type 2 diabetes, developed injury on her right grade 2 lateral side, and hospitalized for knee pain. Conscious and oriented. Injury size is 1 centimeter length and 1.5 centimeter width. Wound is red and appears red and dry. Foot feels cold to touch.
All right.
Okay. Actually, wound classification is it's a diabetic honey wound.
Very good. It's a diabetic wound.
Yeah. Type of wound is a neuropathic. It's not a neuroischemic. Because
So is it neuropathic?
Wound is dry and red.
All right. So how about this one? Why is the foot cold to touch?
No, this is ischemic. Sorry.
I mean, actually, not ischemic also. It's a mix of both. Neuroischemic. Very good.
And daily to be done with the exudate amount is dry and red.
Very good.
And dressing selection is washed with NS. Daily sterile dressing with microbial.
Antimicrobial is required.
Yeah,
Okay.
antimicrobial.
All right. Very good. Thank you. Can you please give a big round of applause? Actually, team 1 and team 3, it's not compulsory that you need to use an antimicrobial dressing. But here, given the scenario of diabetic foot ulcer, to prevent the infection, we can use, all right? Because it's a chronic ulcer and patients tend to develop infection. So instead of waiting for infection to develop, you can apply prior as a prophylaxis an antimicrobial dressing, all right? But whereas the team 2, they already have a necrosis.
right? So it is possible that there could be infection underneath also. Yes. So can we call upon team 3 and their case study is projected here. Team 4, sorry. Please read out the case study.
Classification of the wound is
Case study.
fiber type.
Group is fiber tight, all right. Yes, yes, read out.
Mr. Danish, 32 years old, was diagnosed with type 2 diabetic, developed injury on the left heel, non-balanceable erythema, hospitalized for generalized weakness, conscious and oriented. Injury size, length 2 centimeter, width 3 centimeter, wound bed appears black. He likes spending more time on bed. The wound classification of the wound is pressure ulcer, neuropathic ulcer. The type of wound is grade 1, only spreading on epidermis. Exudate amount, actually it is dry wound. There is no exudate. Dressing selection, actually we have to use in this case Meflex pad for the reducing the grade of the wound. From that onwards it will be reduced. It won't spread anymore. The management of wound in detail means first one is position changing. It is important. Then foot elevation. Then walking therapy and all more.
All right, very good. Thanks a lot. But here, patient can have neuropathy, but ulcer is only called as pressure ulcer. We don't have pressure ulcer and neuropathic ulcer. Uh, because of diabetes, patient may have decreased sensation on their heel or on the foot. So there are more chances for patients with diabetes or neuropathy to develop a pressure ulcer, which is especially on the heel, right? Okay. And management, other things include, you can also include braiding to prevent another pressure ulcer, and also diet, I mean the bundle, skin bundle or a skin bundle. All right. Otherwise, thank you. Thanks a lot. Very good. Can we clap for team 4? So here we end the activity, and then I'll hand off to Miss Risti, my sales colleague, to take about the solutions for diabetic foot ulcers. Means how do you manage an infected diabetic foot ulcer? What kind of dressings or products, and how are they helpful in terms of reducing the wound and also help the wound heal faster?
So, without taking much time, directly focusing on the how we can have a advanced solution for diabetic foot ulcers. So, considerations when treating a wound. What are the considerations we take while treating the wound? So, the first is the health, blood supply, wound diagnosis, mobility, social situation, pain, cost, and wound assessment. So, wound assessment and pain are the main things which we can take as a consideration. I mean, most painful part for a patient, the pain from the wound and the wound assessment. So, Monlike Healthcare brings a patent technology that is called as SafeTech technology, that is less pain and less trauma. SafeTech is a soft silicone. So, if you can see this picture, how dressings do the blisters upon removal of the dressings. I mean, this is for traditional dressings. And blisters can rupture as well while removing or changing the traditional dressing. Now, the second thing is maceration. So, if the sealing is not proper or the optimal moist environment is not maintained under the dressing, then it may cause maceration. But in using of Ceftec technology, there will be a less maceration. So here I will be showing you what are the dressings we have with SafeTech technology and what is the advanced solution for diabetic foot ulcer. So first, regarding something for soft silicone. So soft silicone will benefit for less skin stripping while removal or changing of the dressing, less wound adherence, and less maceration. So here is one video I am playing in which we will show you what is SafeTech technology and how it is benefiting in these 3 points.
Back then, quality of life spurred our compassion to do the right thing. Today, quality of care makes it our responsibility. Pain and dressing changes is avoidable, which means stress and the delayed healing it causes is as well. Just use dressings with SafeTac. SafeTac is a unique updated adhesive technology. Its formula has been refined over more than 20 years. No other adhesive can perform exactly the same way. SafeTac only sticks to dry skin, never to moisture, such as the open wound, and it spreads peel forces over the wider surface at removal. The diluted force isn't strong enough to strip skin cells, meaning less painful and damaging removal. It also adheres to dry skin instantly and can be taken off and repositioned without loss of effectiveness. And no other adhesive has anywhere close to the weight of evidence backing it up. More than 100 peer-reviewed publications over the past 20 years. It's
These in this way in the that was the mode of action of SafeTech layer, that is the soft silicone layer present in every Monlike healthcare dressings, that is named after Mepilex. So I will be quickly showing you what all the dressings we have as our advanced wound care solution for diabetic foot ulcers or infected ulcers. So these are the mode of actions for the dressings: peeling, absorption, retention, and evaporation. So the first layer is backing film, that is viral proof and bacterial proof. Second comes the absorption foam pad that manages the exudate effectively, works under compression as well, and it is highly comfortable. Now the last layer is the first wound contact layer, that is SafeTech technology, the soft silicone layer, which will help to less skin stripping and less wound adherence as well as less maceration. That's why we also call this dressings atraumatic dressing. So Mepilex is our first dressing which I am showing right now. This the name of the product is Mepilex. This comes in like this white pad or off-white color of pad, and it can be cut easily in whatever shape and size we require according to the wound location. Okay, and we can keep an secondary dressing over this Mepilex so that it doesn't have any borders. So secondary dressing might be required depending upon the ulcer location. And as you can see, this Mepilex dressing is very comfortable. It stays in place and does not slip while applying or additional fixation. Now, what are the area of use of these dressings? So leg and foot ulcers, pressure ulcers, wounds with compromised or fragile surrounding skin. Now the features and benefits, it is soft and highly flexible, easy to use, highly comfort. It is atraumatic, and secondary fixation it might apply. We might apply, and it can also work under compression. So this is the Mepilex dressing. It comes in various sizes as well. So this is the application guide for Mepilex dressing. We can cut the dressing in the various sizes for application, depends upon the wound location and the type of wound. Now coming to the Mepilex border heal, this is a specialized dressing which is designed for heal prevention for pressure injury or management of the ulcers. So this is the heel dressing. So heel dressing is comprised of 5 different layers, which takes care for friction, pressure, shear, and microclimate, which should be maintained for prevention of pressure injury. Now coming to Mepilex AG. So what is Mepilex AG? So Mepilex AG is the effective antimicrobial absorbent foam dressing. It has 3 layers inside this. The first layer is same SafeTech layer, soft silicone layer. The second layer is polyurethane foam pad in which silver sulfate ions are present, and the last layer is polyurethane backing film that is waterproof, showerproof, and antimicrobial proof. And as well as, if you can see this dressing having a darkish blackish in color or grayish in color, this is because of the carbon present in the foam pad to take care of the foul smell or odor coming from the infected wounds. Now the same dressings comes in with the borders. So without border, Mepilex AG can be cut in any shape and size, and it can also work under compression as well as can apply in according to the location. And this comes in Mepilex border AG. The same dressings comes in border. Now the mode of action. So the silver present in this dressing is Ag2SO4, that is silver sulfate ion, and after applying the dressing over an infected ulcer, it starts releasing the silver within 30 minutes. So I'll be playing a video in which it is showing how this silver mode of action takes care for a infected wound.
This is an overview of the skin, wound, and Mepilex AG with the SafeTag soft silicone layer. Wound fluid is absorbed into the dressing from the wound bed through the SafeTag layer. The absorbent foam is impregnated with silver sulfate particles. In this dry environment, no silver ions are released. When fluid is absorbed into the foam, it comes into contact with the silver sulfate particles, and silver ions are released into the fluid. The mode of action of silver is due to the silver ion. When the silver ions, Ag+, come into contact with the bacteria, they have an antimicrobial effect on microorganisms. The antimicrobial mode of action of silver can be explained in 3 ways. First of all, cell wall rupture. When Ag+ binds to proteins in the cell wall could break and the contents of the cell could leak out, resulting in the death of the bacterial cell. Secondly, Ag+ might also bind to bacterial enzymes, resulting in the inability of the bacterial cell to perform processes necessary for respiration, or to take in or process nutrients. What's more, the silver ions disturb replication. Ag+ might bind to bacterial cell DNA and interfere with cell division and the replication process. Silver ions in the fluid will strive for equilibrium and thereby divide homogeneously in the wound fluid, both inside and under the dressing. As a result, the silver ions will also be released to the wound.
So in these 3 mode of action, the silver sulfate ion present in the dressing kills the microbes. So the first is it will prevent the microbe from eating and breathing. The second is cell wall rupture, and the third is disruption of replication. Now the area of use, it can use in the management of low to moderate exuding wounds. And the one important point while using the Mepilex AG dressings or Mepilex border AG dressings, we need to keep in mind we cannot use this dressing on a dry wound because some amount of exudate should be there for the silver sulfate ion to release from the foam pad to the wound surface area. So these are the various different, this is the type of diabetic foot ulcer where this Mepilex AG has been applied. Now this is the heel. The same Mepilex AG has been designed for specifically for the heel. So this is the application part. This dressing will require a secondary fixation, and it can also be cut easily in whatever shape and size required. And these are some instructions while using Mepilex AG. Clean the wound with saline solution or water, and we have to wait for few minutes to dry the surrounding skin thoroughly. And then we have to remove the backing removable films present in the dressing, and then we have to apply the dressing, making sure that no air pockets are available if we are using the border dressings. And for best results, Mepilex AG should overlap dry surrounding skin by at least 2 centimeter. Secure Mepilex AG with a bandage or fixation as needed. Thank you. Any questions? Whatever I have explained here for the live demonstration, so that for your better understanding, because these products are approved, and yeah, this is available. So how you can use this dressing? What is the application part?
Thank you so much, Mr. Uma and Mr. Napoleon and Ms. Srishti. Uh, I know it's a great platform to learn on hands-on training. This is what I discussed with Mr. Napoleon. Next time we will have hands-on training. And physically, if I'll take consent from, hospital authorities, from our medical director, as well as, the patient attenders concerns. We have any such kind of sick patients, especially with grade 4 wound ulcers or any diabetic foot ulcers, will take consent from the consultant doctor permission as well as family. And we do on, these kind of dressings, we create awareness for them, and how to dealt with these kind of dressings. So anything, nurses, you feel free to ask questions now because this is a very great platform to learn for you. And this is not that so easy to manage. Wound care management is, lot of preference given for Germany and Japan. When I talk about 2013, I have done this course, wound care management. Almost it was 1 year course which we have dealt from basics. There is lot of information about wound care, and the Molekin company so much support, and they have come to us to talk about nursing fraternity, to learn good practices and how to adopt, and how you make sure that a wound should be healed very well, and which 24 into 7 we are nurses, we will take care of patients, apart from consultant, apart from surgical team, apart from your diabetic nurse or wound care nurse. The nurse on bedside will take over, and she knows what is, what pain patient is going through and how you want to deal day in day out. So you're the part of stakeholders. So folks, I'm requesting you guys to ask for questions. If you don't have any questions, I request Napoleon and Uma team, next time they come physically next week, or we can take bedside trainings and some more mannequins on hands-on training with practicality. By one-to-one sessions will conduct. So thank you. So nice of you, Uma. You have done wonderful experiment, and nurses has gained knowledge from this topic. So now I would like to call Miss Martina, Miss Mrudula to give a vote of thanks. I think Miss Martina will take over the session. Kindly, I request Miss Martina to take the podium.
Nothing new can come into our life unless you are grateful for what you already have, says Michael. We are grateful to God who really made this event wonderfully done. The medico teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires, says William. We are indeed inspired by all doctors who really contributed their best. Thank you to all the resource persons. A special thanks to Dr. Sharath Reddy sir, the program director of Medicare Hospitals, who always inspire and update us by arranging seminars to update our knowledge. A sincere thanks to Dr. Rakesh Prabhu sir, the program co-director of Medicare Hospitals. Thank you sir for your helping hands in arranging this symposium. An investment is knowledge, the pace, the best interest, says Benjamin. Thank you very much, ma'am. Ms. Swati Meda, our group nursing educator of Medicare Hospitals, for making us invest in knowledge, which is really a great investment for our professional. We assure you your interest to make use. Thank you, ma'am. As we express our gratitude, we must never forget that the highest appreciation is not to utter the word, but to live by them. We assure you that we have received an update message today to make our professional and take the promises to live it. Thank you very much for all the participants, and thank you one and all.
Last but not least, I would like to thank Molekin Company, Mr. Uma Maheshwar and team. And I would like to thank our IT team and our digital media. And I would like to thank our housekeeping services and our F&B manager, F&B team with a delicious lunch which they have provided, snacks. And I would like to thank each and every nursing head and nurse educator, whoever, offline and online, to make this program successfully. We cannot stop our knowledge. I always, tell my nurses, you need to update yourself and upgrade your protocols and with evidence-based practices. So knowledge is always, it is like divine. You always have to have adopt the culture to, make it habituate to learn something every day new, and you need to adopt your that culture to become a habit and to practice on patient care. So this is what I would like to circulate to for everyone, and proactively every nurse should take ownership and accountability. And you are the folks and healthcare fraternity today, the world is, talk about so much, and you all the part of members, and you need to take care of that. So once again, thank you so much everyone. I would like to gather all my nurses to take a photograph along with Molekin Company. Please kindly join with us so we can end the session. Thank you so much for patient listening. Thank you for all my nursing fraternity and my medical fraternity to support for this event successfully. Thank you so much.